Welcome everybody on day 2 of our summit. I'd first like to take the time to introduce me and my brother. So some of you may remember me from lobbying back in 2023, but those who don't know me, my name is Lauren Kim and we're both from California. This year I brought along my brother Daniel to also share his perspective. But before we get started, I would like to thank all of our sponsors of this year's summit. So it's up on the board. And then the Wi-Fi information for this year's program is also on the screen. So we'll take a moment if anyone needs to connect to the Wi-Fi. Okay. So the title of this year's presentation is Voices of the Next Generation, and we want to take the time to kind of share the youth perspective of stomach cancer. So before I start, I think it's only fitting to kind of share how we got into advocacy and how we joined Hope for Stomach Cancer. So when my father was turning 50, he was scheduled to go in for a routine colonoscopy, but his friend suggested to also get an endoscopy as well because he was going to be under sedation. And after his exam, we received the shocking news that he had stomach cancer just the day before his 50th birthday. And unfortunately, unlike colon cancer and colonoscopies, there are no guidelines for endoscopies. At the time, my parents didn't want to worry my brother and me, but I sensed something was wrong. I felt lost, and I thought that asking them about it would stress them out and burden them even more. Typical of my generation, I turned to the internet for answers, but nothing made sense because of all the difficult medical terminology, and it just gave us a lot of scares. It was then my dad's surgeon, Dr. Yang Hee Woo, who will be also speaking today, connected me to Hope for Stomach Cancer.
For me, it was hard to process everything at first. I was young and didn't fully understand the seriousness of the situation. But as I got older and saw my dad go through surgery, checkups, and recovery, I realized just how much strength he had and how much strength my sister showed too. I looked up to her as she turned her fear and confusion to action. She became an advocate for not just for our dad, but for so many others. That inspired me to want to help too.
With Hope for Stomach Cancer, I went to Washington, D.C. to ask Congress for greater research funding to promote early detection and prevention. That experience helped me develop my passion for advocacy. Through this work, I've learned so much from Mrs. Smith from Hope for Stomach Cancer and Dr. Wu at City of Hope. Being a part of these organizations gave me insight into the bravery of patients and caregivers, the dedication of doctors, and the unselfish commitment of volunteers. All working to make a solution for gastric cancer closer. And from my personal experience, I wanted to provide support for the youth like myself who may dealt with a similar situation as I did. I began creating a brochure that simplifies medical information, clears up common misconceptions, and connects youth to support groups like Hope for Stomach Cancer.
I've been also able to help my sister with this project by sharing my perspective as someone who didn't know much about stomach cancer at first. One of the things we want to do is to make sure that young people like us have resources that are easy to understand. The brochure will include links to peer support groups because sometimes just talking to someone your own age can make a huge difference.
So then in this pamphlet, I wanted to cover some misconceptions that we covered. So when I first turned to the internet, I found so much misinformation and it made me even more worried. I realized that youth might be facing similar and having the same questions as I did, so I'd like to address some common misconceptions about stomach cancer.
Here's an example. Does stomach cancer always cause pain, bloating, diarrhea, or nausea?
And no, it doesn't. That's why it is so important to get routine checkups and in certain cases endoscopies, especially amongst Asian and Hispanic cultures where foods are often spicy, salty, and shared. This increases the transmission of H. pylori, the strongest known risk factor for gastric cancer.
Another question I had was, how can you survive without a stomach? When I heard that my dad was going to have part of his stomach removed, I was scared. I thought, how is that even possible? And what will life look like for him?
And it turns out, this was a big one for me, you can live without a stomach. The body is able to adapt and bypass the stomach's main functions like storing and breaking down food.
One more misconception we like to clear up. Is stomach cancer hereditary?
While it is rare, it can be hereditary. Gene testing is now available for families to check for mutations that might increase their risks. The internet and gathering information about stomach cancer diagnosis are often very intimidating. Therefore, it is important to educate the youth on these facts so that they can take their own preventative measures. And at this time, I would like to take a moment to welcome up our new advocates who joined our initiative in lobbying. I want to give them an opportunity to share their experiences with stomach cancer. So first up, I would like to welcome up Maddie Jo.
Friend of Jules. Can you hear me now? Yes. Okay. Sorry, I talk really quiet. Throughout all of high school and through all of my middle school experience, Jules was someone who I found myself looking up to. She was brave and kind and just, just like truly the best person. And when she was diagnosed, I was super scared. And, you know, my mom's in healthcare, and so we had a lot of talks with my mom about treatment and options for stomach cancer, and we knew that there weren't many. And even through Jules' sickness, she would go out of her way to send encouragement, which was so huge. And so I'm, not always the most positive person, but now in any tough situation, I think back to Jules and how she was going through something that I couldn't even imagine, and she would go out of her way to send encouragement to us. She was encouraging teammates and friends and people that she really didn't even know. I'm so sorry. And so I just try to live life now thinking, through any tough thing, if Joel can do it, so can I. So yeah, my impact was really just trying to live more fearlessly and to be more intentional with my encouragement, because that's who Joel was.
I'd like to next welcome up Davis, who would also be sharing her experience with stomach cancer. And yeah.
My name is Davis Reeder. Is this too loud? I feel like I'm so close to it. I'm a crier, and so this might get a little ugly, so that's my apology. I'm also going to read it right off my phone because I can't freestyle this. My knowledge of stomach cancer began in 2017 when my grandmother passed away. I knew that she was sick for a few months before she passed, but after she passed, I really learned the gravity of the situation. She had a uterine cancer that metastasized to her stomach, and it was then that I learned the severity of cancer that either originates or metastasizes to the stomach. This information stuck in my mind, and later, in February of 2020, I learned that my friend Jewel was diagnosed with stomach cancer. Sorry. I need 5 seconds. I remember being really confused because I thought that stomach cancer only affected older people. I remember Googling treatments for pediatric stomach cancer and being really confused that there was nothing on the internet. I went to my school's Google Scholar account, so I had access to real medical literature. And I also found nothing. Sorry. I was met with little to no information regarding the subject. I was sad, but I also felt hopeful that there were medical professionals who had access to information that I didn't. I'm not naturally an optimist, but seeing the strength that Jewel had throughout her experience with cancer genuinely made me feel like she would be okay. I remember seeing pictures of her on social media when she was sick and admiring how bright she still seemed despite what she was going through. I found out that Jewel passed away on December 19th of 2020, and I was filled with sadness for her family and friends, but more than that, I was crippled by how unfair the entire situation was. The screening for stomach cancer is so poor, and the treatment options are even worse. Jewel was such a bright person, and she deserved better than that. Later on in 2022, I was diagnosed with cancer myself. I was diagnosed with acute myeloid leukemia, and I began treatment on August 1st, 2022. When I first heard the news, I started to Google. I had so many thoughts in my mind, but the main one was how few options I remember Jewel having. As I researched, I found out that I had a few curative options, and I was filled with gratitude, but at the same time, I just couldn't shake how unfair everything felt. I remember telling myself when I was sick that if I got better, I would fix it. I didn't know what fix meant, and I didn't know what it was, but I knew there had to be something more that could be done. I didn't see a reason why people wouldn't have any curative options. Jewel's memory gave me so much strength during this time that I often find it hard to reflect on my own experience without thinking about her. Sorry. I ended up going into remission and eventually started college. Now I'm a sophomore at LSU, and I study biological engineering. I hope to begin a career in either pharmaceutical development or tissue engineering. Learning about medical and technological advancements gives me hope that we're closer to having more options for people who are fighting against the odds. My biggest dream is that I could be a part of that, and I know without a doubt that Jewel is a catalyst for me thinking this way. So I'm becoming a biological engineer for Jewel. So, yay!
And I feel like what I wanted to take away with these stories was, I guess, how stomach cancer and any cancer affects the youth and how it could affect our emotional and mental. But I think in the midst of it all, I feel like we can't have fear get in the way of this. And I feel like the latter kind of takes us further. We need to respond with compassion and empathy for each other. And I feel like that's mainly the highlight. So I believe organizations like Hope for Stomach Cancer have been vital in providing resources and support to patients, caregivers, and their families.
For youth, there's also emotional support groups like Teen Talk. These groups give kids and teens a safe place to share their feelings and find encouragement from peers who understand what they're going through.
If you have a youth in your life who might benefit from these resources, please don't hesitate to reach out to us or organizations like Teen Talk and Hope for Stomach Cancer. We are so grateful for the chance to share our story this afternoon. It is our hope that by talking about these experiences and sharing other people's voices, we can inspire hope, resilience, and action. I'm excited to be back here in DC, lobbying with a bunch of new people. It's very nice to see more people joining our initiative.
Thank you for listening to our story and supporting important organizations like Hope for Stomach Cancer.
And for those of you who have any questions for us, please feel free to come up to us during our lunch break. We will be taking a lunch break now, and we'll be back here at 1 p.m. for our educational sessions, and lunch is provided for you out in the hall. Yes.
One more seat. They have a Isabel.
Yes, please come up.
Good morning, all. My apologies for kind of this this late addition, but my daughter, my oldest daughter, 19. I have a 19-year-old and a 9-year-old, and boy, this has been just a traumatic experience for both of them. My husband passed September 8th, so their dad, passed just a couple months ago. They are both incredibly brave. But she's a bit of an emotional person and couldn't handle coming up with that. So I put a couple of talking points together that I just wanted to share about her. At the time, she was going to college. She got accepted into FSU. We were moving her into a dorm. And my husband, as we were putting together all of her bed together, her large carpet, the rug together, all of the nice fixings to make it just perfect, because she would be about 3 hours away from us. We started to notice that her dad was so fatigued. I mean, just at some of the simplest tasks, he was very fatigued, and that's when she started noticing, okay, something is off. This is not right. So, we went back home and we did our due diligence, and we found out the devastating news. So we shared it with her, and she is my empath. She feels everything. You tell her something and she feels it in her soul. She rushed home and she became a caregiver, just like me. In rushing back home, it was only going to be temporary. It's going to be 2 weeks, maybe. See how things were going. And she went back, and after 3 days, she said, I can't not be there. I cannot not be there. And she would connect with friends. And the friends, that impact on her. There were some, you don't know what to say. Some of them did not know what to say. They would just say, I just want to hug you in this instance. I'm here for you. And others, they didn't understand why she was then also staying. So then she would kind of get criticized on what, your dad wants you to go live your life. Why don't you, go back to college? And so there was some resistance there, and finding some of that comfort and some of those healing words. I know that was difficult for her. It really was. There was no right answer either. But the level of comfort, it was different. With that, finally, sacrifices are made too with the kids. Boy, our house was always welcome to friends, and my kids skipped inviting friends over for fear of it would possibly make their dad sick. Going to big events, dance competitions, pageants. My girls did pageants too. He would sit in the back. Not up front like he normally would, but in the back, so that he wasn't, he didn't get sick or anything. It wasn't as accessible if he did get fatigued and things like that. So with that, I appreciate your time in this. I appreciate you letting me hear, or letting me tell you about my daughter's story. She's wonderful, and we cannot wait to fight for current patients, future patients, and additional advocacy for all.
Thank you so much. Thank you.
Yeah.
Thank you. Okay. That's it. And now we'll be on our lunch break.
Good afternoon, everybody. Thank you so much for being here, and thank you so much for the invitation for me to join this amazing event. I am humbled by everybody who is here and eager to learn from all of you and share some of the knowledge as a medical oncologist. My name is Natalia Uboha. I am a medical oncologist specializing in treating cancers, patients with gastrointestinal cancers. I practice at University of Wisconsin. I have a particular focus on upper GI tumors. I also lead our early phase oncology therapeutics program, which is the program that's dedicated to developing new drugs for patients across with different types of cancers. And again, I am honored to be here. I would like to introduce our first speaker of the day, Dr. Yangyi Wu. She is a professor of surgery at City of Hope Comprehensive Cancer Center and is an internationally recognized surgeon scientist specializing in robotic surgery and gastric cancer. As Vice Chair of International Affairs and Community Outreach and Director of Minimally Invasive Therapies, she leads innovative surgical treatments, including robotic gastrectomy, D2 lymphadenectomy, and HIPEC, serving a diverse patient population. Dr. Wu spearheads transformative research to eliminate gastric cancer death with funding from NIH, Department of Defense, SU2C, and the Cure Foundation. Unfortunately, Dr. Wu is not able to be with us today, though we are very fortunate that she's able to join us via Zoom. Welcome, Dr. Wu.
Hi, thank you so much for the kind introduction. I am so sorry I can't be there, but my heart is there with you guys, and I have a presentation for you. I was asked by Aki to talk about surgical management and multidisciplinary care. I started out with thinking that I would have a few slides, but I have a little bit more than that. Hopefully I can get through it quickly, and I'll be open to questions very soon. Can I share my slides, you think? Yes? Is that a yes? Do you see my slides at all?
Yes.
You see my slides?
Yes.
Okay, hold on one second.
We can see them.
You can see the slides?
Yes.
Okay, great. In slide presentation mode, hopefully?
Yes.
Okay, great. So today I'm going to be talking about what should we know about stomach cancer surgery and the multidisciplinary care team. As I was just introduced, I'm sending you greetings from California. Currently here, the temperature is not as cold as over there. I've been a surgeon scientist for about 14 years now, and I joined City of Hope, where I practice right now, in 2015. 50% of my time I do patient care, and 50% of my time I do research in viruses that kill cancer, and hopefully it'll be in patients with gastric cancer soon. So our vision is to eliminate stomach cancer deaths. And the mission is to provide the best treatment strategy and optimize management of our stomach cancer patients. As the audience is mostly stomach cancer patients and their advocates, this should be what is expected, that you should receive the best care that is possible right now in the United States when you go seek care from your physicians. The best treatment strategy we know today is tailored to the patient. What I learned from my years of practice with you and caring for stomach cancer patients, that it involves a lot of courage, requires knowledge, vigilance, trust, dedication, hope, faith, and love. And a patient that is going to become well-informed, and you should build your care team and support group like you're doing right now, and ask many questions and get the answers that you deserve. And some of the care that you should seek is multidisciplinary, meaning there should be, if you have a cancer that's more advanced, you should have a surgical oncologist, a medical oncologist, perhaps a radiation oncologist, gastroenterologist, etc., that I'll be talking about. Inquire about, precision oncology-based systemic treatments. And if you're a candidate for surgery, ask about minimally invasive surgery and robotics as part of your options. And then always, if there is a clinical trial right for you, standard of care does not seem to be sufficient. So multidisciplinary team for gastric cancer, full of gastric cancer experts who are dedicated to treatment of stomach cancer patients is ideal. So you should have a gastroenterologist in the beginning when you get your diagnosis, and you should meet a surgical oncologist who can offer you these options of surgery if needed, and a medical oncologist who will be giving you your chemotherapy and other therapies before and after surgery. And sometimes, and less often, will you need a radiation oncologist, and then, have the supportive medicine team and have a multidisciplinary tumor board perhaps discuss your care to find the best options. And at times you will meet with a nutritionist, a physical therapist, dietitians, etc., to learn about what happens after surgery in terms of eating and your diet and nutrition. So one thing that I wanted to bring up is that before we could provide you with the best treatment strategy or surgical options, it's very important to get accurate staging. So to be equipped with knowledge about your stomach cancer, I wanted to share the reasons that we would do an endoscopic ultrasound. And an endoscopic ultrasound is like an endoscopy, but performed by an interventional GI. So not every gastroenterologist can do it. It helps the surgeon plan the extent of nodal dissection, the extent of surgery that we need to do, and it provides for best surgical outcomes. So endoscopic ultrasound is the best method to distinguish between early gastric cancer, which is few and far between in the United States, about 20%. And most of you will be diagnosed with advanced stage gastric cancer, which is resectable. But if your cancer is already seen on a CT scan to be nearly obstructing or have bulky lymph nodes, and then an endoscopic ultrasound is not needed. Accurate clinical T staging is essential to predict nodal metastases and inform treatment strategy and plan the extent of surgery, especially the nodal dissection. Here you'll see that there is a predicted nodal metastases involvement of your nodes with the cancer based on your T stage. And also, it could also predict the rate of potential peritoneal carcinomatosis. So if you have an early cancer, your risk of peritoneal metastases at the time of your diagnosis is 0%, whereas you still have a small percentage of risk of having nodes. And the accuracy of endoscopic ultrasound, like everything in medicine, is never 100%, but it's pretty good, and it's very based on the person doing the procedure. So the next thing that when you're diagnosed with advanced stage, locally advanced resectable stomach cancer, staging laparoscopy is critical. It's recommended by the NCCN guidelines for any patient with T1B or greater. That's why this staging endoscopy may be very important to you. Staging laparoscopy can find up to 30% cancer that is not in the peritoneum, that is not seen on the CT scan. And at COH, here at City of Hope, for all gastric cancer patients who are going to be undergoing neoadjuvant treatment, we receive laparoscopy for peritoneal diagnosis prior to the first dose of their treatment. So in order for this to happen, the early communication between a surgical oncologist and a medical oncologist is key. This is just a picture of a patient who had suspected peritoneal metastases at the time of a CT scan. But when we went in, we saw a lot more disease than we had expected. If found to have peritoneal disease, obviously the treatment plan will change. So, then also the biomarker testing, when you get your staging information, we also nowadays are doing for not just for metastatic gastric cancer, for locally advanced testing for biomarkers in your tumor, for HER2, PD-L1. And one of the most important things that may affect surgery and neoadjuvant treatment is your testing for microsatellite instability of your tumor. It's been found that patients with MSI high cancers have a good prognostic outcome after surgery. They have the best compared to the ones that do not have MSI high, and they do not respond to chemotherapy. So the recommendation now is that for patients who have MSI high tumors, either you go to upfront surgery alone or get neoadjuvant immunotherapy. And that's a discussion you should have. But knowing the status of your tumor is very important to make those decisions. So, just to go on to the importance of proper timing and extent of surgery, essentially, gastric cancer is not that common in the United States, and there are very few experts who have high volume. If you have an advanced disease that with complicated or complex surgical needs, then you should be seeking a high volume surgeon at a stomach cancer or a cancer center with stomach cancer expertise. So because there's been some really key progress in the curative intent surgery, there are 3 factors that impact the timing, extent, and approach. And these are the discussions that should be had with both your medical oncologist and your surgical oncologist. D2 lymphadenectomy is a procedure to remove the lymph nodes that drain the potentially cancer harboring lymph nodes that are in your body. And it is now recommended to do this extended lymphadenectomy for all locally advanced gastric cancer patients who can tolerate it. And the second key factor is minimally invasive surgery. This affects not only the long-term outcome, but it affects your quality of life. And there are 2 approaches, laparoscopic and robotic. And it's been shown that the robotic approach, because the laparoscopic approach can be very challenging for some surgeons, robotic approach can help perform this minimally invasive method of doing the lymphadenectomy. And as you can see the picture here, on the right of the stomach and all the lymph nodes stationed by number, and there's a special technique to remove these stations. And here is the ports, small incisions made to do a big operation on the inside. And by far, the most important aspect, I think, other than the D2 lymphadenectomy, is the fact that we are giving chemo before and after surgery for these MSS tumors, which will be about 90% of you out there, either FLOT or FOLFOX based on your age and health. So optimal advanced gastric cancer patient outcome depends on proper incorporation of these advancements in your treatment strategy to make sure that you have the best chance at a cancer-free life. So multidisciplinary because it's complicated and complex, the multidisciplinary discussion for optimal timing and extent of surgery is very important. It's just summarized here. So the endoscopy requires a gastroenterologist, especially a pathologist, and then a centralized multidisciplinary review with medical oncology and surgery and other experts. And this is sort of the summary of what we would be considering for these types of tumors. And then and clinical trial, if there is any, for neoadjuvant therapy. So the surgical approach for gastric cancer is actually a surgeon's choice, but it could be your choice depending on which surgeon you have. So open surgery has been practiced for over a century, and that is actually the standard of care. And by far, in the United States, most surgeons perform open surgery for stomach cancer. But there are experts who can do it laparoscopically, and then there are increasing number of surgeons offering robot-assisted gastrectomy. So surgical approach is surgeon's choice. It's usually based on their training, comfort, and expertise. But regardless of these approaches, the goal remains the same. First, it's surgical cure, doing the best cancer operation that is possible. And secondly is functional preservation. Only take what we need and reconstruct in a way that you can maintain your quality of life. And to give you just an insight about robotic or laparoscopic approach, the minimally invasive surgery approach is selected based on many patient factors and not necessarily just tumor alone, but tumor characteristics, surgeon training experience, not all surgeons offer minimally invasive gastrectomy, and not all patients are suitable for it, because we want to make sure that the operation we perform can be done safely and the best for a surgical cure. And this is just a picture of what happens when you put an instrument inside. You can see we're doing the lymphadenectomy with instruments through these small incisions. On the inside, the operation is the same. So one other thing that I would say for those of you who are planning to undergo surgery or have undergone surgery is the importance of a pathologist. I wanted to share our expert pathologist, because patients never actually meet him. You only get a pathology results like this. But one thing to remember is that, on the pathology report, we want to make sure that you have at least 29 lymph nodes evaluated. Here we had 49. And all of the regional lymph nodes were negative for tumor. For this patient, that's important because 0 out of 46 lymph nodes is very good in terms of prognosis compared to having like 15 lymph nodes evaluated to be uncertain whether or not there are other positive lymph nodes there. And then understanding after your surgery, your risk of recurrence after a curative intent gastrectomy. If you have higher TNM staging, obviously you have an increased risk. Proximal location, diffuse type compared to intestinal type has an increased risk of peritoneal carcinomatosis, larger tumor size, lymphovascular involvement. These are all characteristics of the tumor that are available on your pathology, and the lymph nodes that are positive compared to the negatives. And we always check for PD-L1, HER2, MSS. So if you're PD-L1 positive and MSS tumors are increased risk of recurrence. What is the good news is that if you had a very complete surgery, decreases your risk of recurrence. If you have no lymph nodes positive with increasing lymph nodes assessed, it also decreases your chance of recurrence. And then having multimodal treatment also decreases your risk of recurrence. In California, the data shows that if you are treated at a comprehensive cancer center, it improves your survival rate compared to a non-comprehensive cancer center treatment. So there are some unanswered questions that many people have, and a lot of times at Hope for Stomach Cancer advocacy meetings, we have patients who have peritoneal metastases, and there's a lot of questions about intraperitoneal chemotherapy and conversion surgery for these patients. And one thing to note is that despite our best treatment for our patients, there is a high peritoneal failure rate for advanced cancer patients. And it is the most difficult to treat of many of the metastases. It's the leading distant metastatic site. It used to be the liver, but now it is peritoneum in the US. After flawed and gastrectomy with D2, there is up to a 56% recurrence rate. There's a 56% of all the recurrences happen within the peritoneum. And at the time of autopsy, 60% of patients with stomach cancer had peritoneal metastases in some of the studies. Recurrences are often within 2 years, and you can see the overall survival. So there are options for regional therapy for peritoneal carcinomatosis, but in the United States, all of these options are investigational. And while some centers like City of Hope will offer some of these, like HIPEC off of clinical trial, most of these are investigational at this time. And, there's evidence over the years and why people are trying to investigate this along with systemic therapy. At City of Hope, we have a phase 1 trial that will be opening next month in PIPEC for second line with the drug nab-paclitaxel delivered with pressurized intraperitoneal chemotherapy along with systemic therapies in second line. So we do not de-escalate the care that is known to be optimized for our patients. So we still have these unanswered questions. And worldwide, the current strategies include the HIPEC, IP chemo, and HIPEC. And we still need to figure out the timing, the dosage scheduling between IV and PIPEC dosing, for example, optimal patient selection. Is it best for which one of these is best for cytology positive patients versus those who have really high peritoneal tumor burden? PCI score is the number you get by the amount of disease that you have in your peritoneum. So, right now we have the first line that is recommended, second line, and then many, many clinical trials with systemic treatment, immunotherapy, targeted agents. But somewhere amongst those, for patients with peritoneal carcinomatosis, we will be continuing to investigate the role of regional therapy in these patients. And if you have any questions about it, you should go seek care at a place that provides that. So summary about stomach cancer care. Stomach cancer is very heterogeneous disease where patient-tailored treatment is becoming more complex, but definitely improving survival. Accurate diagnosis staging is a must. You should seek multimodality treatment for locally advanced cancer and a strategy made specifically for you. One of the challenges that stomach cancer is uncommon cancer in the U.S. with 27,000 patients diagnosed each year, few high volume centers and dedicated experts, making it difficult for you to find the care that you trust, but they're out there. So you build your multidisciplinary care team, seek surgical expertise, and make informed decisions. If needed, ask for a second opinion. And I wanted to share that we will never forget and continue those we have lost to stomach cancer and continue to fight against the stomach cancer together. And thank you for all coming to the advocacy educational session. And thank you for your attention. Open to questions.
Dr. Wu, thank you so much for this excellent presentation. We will now take questions, and please raise your hand and wait for a microphone so that everybody can hear you.
Hello, this is an easy question, I think, but not easy for us. You said it's important to have doctors that have a high volume of gastric cancer patients before. What's high? I don't know how many is high.
So for surgeons, it's more than 20 a year. That in the United States, if you go to like Japan, China, and Korea, high volume is considered 200. Akeem may know this number better, but in the United States, I think we have only about a dozen or so high volume surgeons that practice more than this a year in the United States. That doesn't mean that there are not other surgeons who can perform the operation well if they're surgical oncologists with high volume of other related cancer surgeries. But there are some expertise required in doing the D2 lymphadenectomy, and that's sort of the questions that you should ask your surgeon.
Thank you.
So what is PIPAC? That slide went by too fast for me to digest exactly what it is. Thanks.
Yeah, so PIPEC stands for pressurized intraperitoneally delivered chemotherapy. So it's I had a picture, but I took it out. It's a method of delivery of chemotherapy and can be used for other drugs, but like a small pen, it's the size of a pen, and it delivers attached to a machine pressurized chemotherapy, and can be done through small incisions and minimally invasive surgery like when you get your diagnostic laparoscopy, it's like supercharged diagnostic laparoscopy. So the pressurized intraperitoneal chemotherapy has demonstrated very high concentration of chemotherapy at low doses directly to peritoneal cancers. And globally, there's been more than, I believe, 300 to 500 patients treated with over 1,000 pipette procedures. It's also used for other cancers that go to the peritoneum, like appendiceal cancer, cholangiocarcinoma, ovarian cancer, colon cancer, pancreatic cancer. So it's not just for stomach cancer patients, but it is for patients who have peritoneal metastases. Studies have demonstrated that there is very high rate of efficacy. One of the biggest concerns is the durability of that response. The other is that in the United States, there is no FDA-approved pipette device that has been demonstrated to be safe. So the Pipette US Consortium that includes City of Hope, includes Northwell, and Mayo Clinic in Florida have been conducting phase 1 trials to get the safety and efficacy data for the FDA to approve these devices. At City of Hope, we're going to have a phase 1 trial for second line to get FDA approval for the use of these pens in gastric cancer patients. There's also other trials for other cancers as well.
Hi, you mentioned that there's a 56% recurrence of peritoneum for
No,
patients.
the recurrence rates for patients that recur, 56% of them have been found to be in the peritoneum. Most of the recurrences that occur, the 5-year survival for most of our patients, the percentage of people who survive 5 years is about 70-something percent right now, because the 5-year survival in locally advanced cancer is less than 5% for some patients. So, but the recurrence rates that happen, the majority of those patients are recurring in the peritoneum within 2 years.
Okay,
the patients who recur.
So you had mentioned that those who've already gone through chemotherapy have their stomachs removed.
Yes.
50% will have.
No, it depends on stage.
Yeah, stage 4. I mean, stage 4, you're done. It's already been all over your intestines. It's your gastric
cancer. If you have stage
cancer.
4 cancer, 5-year survival for stage 4 is less than 5%.
So when you mentioned getting to know your pathology reports, get your pathology reports after you've had everything removed, you're talking a total gastrectomy and esophagectomy, everything that's already gone. Where should your surgeon be getting a pathology report? Where in your perineum, and how often should you be getting these reports?
Sorry, I'm not understanding your question. Your question is after you recur in the peritoneum? Is that the question? Where can you find where can you get more pathology?
Yeah, there's surveillance. You said that after you've had chemotherapy and your stomach has been removed, the reoccurrence of you coming or growing or metastasizing, I want to know how often should you be getting a pathology report, or how often should you be getting a biopsy, I guess is my question. How often should you be getting a biopsy post-gastrectomy?
Sure, I see. There are NCCN guidelines for surveillance and follow-up based on your stage of cancer. If it's not stage 4, looking for recurrence, which includes an endoscopy and CT scans. Frequency will depend on 3 to 6 months, depending on how the stage of your cancer. One thing that I would add is for patients who are at high risk, like those risk profile that I shared, high risk of peritoneal recurrence, I do recommend that you along with the CT scan or a PET CT that is recommended by a medical oncologist, we would also do a diagnostic restaging laparoscopy for washings and peritoneal evaluation. It could be every 6 months or depending on your actual risk profile. Some medical oncologists, and I would defer to medical oncology, but we also get ctDNA to look for recurrence of cancer. But because there is a 30% false negative rate with those, I don't fully depend on that alone.
Okay, that
So it's
would
a combination of all of the workup.
okay, that would make more sense because if you had a total gastrectomy and esophagectomy, an endoscopy doesn't make sense to me.
Endoscopy can be helpful because sometimes recurrences do happen locally. About 25% of the time, patients, despite the fact that they've had most of their, all the stomach or part of their esophagus removed, some of the recurrences do happen in the more proximal esophagus. And those patients who've had half the stomach or half the esophagus removed, some of the recurrences can happen in the stomach. That is possible. So endoscopy should also be performed annually, and also to look for reflux, esophagitis, etc., and the healing of your surgery as well.
Okay, thank you.
Hi, Dr. Wu. Happy
Hi.
belated birthday.
Oh, thank you. Who's that? I can't see you. I can only see the back of you.
Oh, this is, hold on, let me turn it on. It's Albert Carrasco. How you doing?
Hi.
Hey, so in some patients, like Brandy, we had a decreased pancreatic function, and she was taking supplements like Creon or pancrelipase. Since then, I've seen that there are, let's say, synthetic or artificial pancreases. Are those an option for patients nowadays, or are they plausible?
Synthetic or artificial pancreases? I am not aware of that at all.
Okay.
But the supplemental with pancreatic enzymes, I've seen many of my patients after gastrectomy requiring that, and it's been helping to gain some weight in as well. But I'll find out more about the synthetic pancreases. Are you talking about transplants?
Or transplant, yeah. I guess anything that would, because in some cases, the pancreatic function, like Brandy, it came back, which I still don't know how she did. But for other people, it gets worse, and it may cause like liver issues or something, right? So if it's an
Let
option.
me look into that for you if you want to.
Sure.
I can reach out to you later if you leave Aki your contact information.
Okay, I'll be sure to. Thanks.
Yeah.
All right, thanks, Dr. Wu.
Dr. Wu, thank you again so much for joining us today. We really appreciate it.
Thank
It's a
you.
pleasure to hear you speak. I know we've crossed paths in other instances, and
Yeah, I just saw you last
you're
month.
such a breadth of knowledge. So thank you. I'm sure everybody found it very informative. Thank you.
Sorry I can't be there. Bye.
So we'll move to the next portion, and I will talk a little bit about personalizing care for our patients with gastroesophageal junction tumors from medical oncology perspective. And then you'll hear also a presentation from Dr. Mukherjee. We'll take questions after we're both done speaking, so bear with us. And then we'll have Dr. Taylor come on stage with us as well, and I'll introduce them after my presentation. So again, I am an associate professor of medical oncology, University of Wisconsin, and my focus is upper GI tumors and development of new agents for treatment of patients with various malignancies. Here are my relevant disclosures. To start, I'm going to state the obvious, but when we talk about patients who have upper GI tumors, we talk about people who have very different diseases. Patients with gastroesophageal junction tumors versus diffuse gastric cancers have different diseases, not only anatomically where they start, but also these tumors have different biology. And so we really need to know patients' tumors, need to know the stage, as Dr. Wu alluded to, so that we can come up with the best treatments for our patients. Knowledge is key. There's many different drugs that are being developed for patients with gastric cancer, which is very encouraging. Some of them are further along, some of them are further behind, but it is incredible to see a breadth of different agents that are coming to clinical practice. Most of these drugs are not chemo. In fact, there's very few drugs that are being developed that are just pure chemo. And you'll hear about this a little more in one of the other talks, but We are seeing immunotherapy. We are seeing what we call bispecific antibody. Antibodies tell my patients like a hook that binds to the tumor cells and can either bring immune cells to the tumor cells or just turn off the antennas on the tumor cells on its own. Now we're seeing the antibodies that can bind multiple different spots on one tumor cells or can bring different cells together. The chemo that being developed, the most common types of drugs we're seeing are these antibody drug conjugates. This is what I tell patients is targeted chemo. It's basically a hybrid molecule. It's half antibody, half hook that brings kind of what we call a payload or chemo with it. We also seeing targeted drugs. These are not chemo drugs at all. These are the drugs that turn off the signaling inside the cancer cells, or turning off the engine of the cancer cells that makes the cancer cells divide. And there's even cell-based therapies. And this is basically taking patients' immune cells, reprogramming them in the lab, and giving back to the patient so that these cells now, patients' own cells, are able to attack the cancer cells. So there is a breadth of knowledge, breadth of research, and a lot of exciting drugs in development. But what's important, the way we can really tailor patients' treatments is to really know the tumors and really characterize the tumors in a greater extent. So you heard already about MSI and HER2 and PD-L1 biomarkers. So I would like to spend a little bit of time telling you how we test for these biomarkers, because I think it's important to understand what we mean when we actually spit out these abbreviations and compilations of letters to our patients. And I draw a lot of pictures for my patients and really try to explain what these are, because I think if people understand why they are and why it's important, then people will be asking the right questions. In my clinic, I have nurses come to the visits with me with patients so that they know that they can help me get all the right information for my patients. So this is the cartoon that I made on PowerPoint. So I'm sorry if this is not fancy, but okay, let me see what I can. So this is a normal cell. I'm relearning some of this with my daughter who is in middle school now. But so this is, actually, I'm relearning the structure of the eye. That's harder than the normal cell. So this is the nucleus. DNA is in the nucleus. That's what makes, that's where kind of the coding material in the cell. And from DNA, you can get proteins that are both inside and on the surface. So this is the surface of the cell, okay? In cancer cells, the normal cells can be, the cancer cell is basically a cell that doesn't function normally. And it can happen for many different reasons. One reason, and this is again oversimplified, but I just want people to understand what we are talking about when we are testing for biomarkers. One way is there could be mutations in the gene itself. And when there are mutations in the genome, all of a sudden, these normal cells on the surface, they're off. Either there's too many of them or they're functioning constantly, so they're abnormal. The way we test for mutations, as you might have heard is from your doctors, is via NGS testing, next generation sequencing. So when the tumor tissue is being sent to KRAS or Tempus or Foundation Medicine, that's what they do. They look at 500 plus different genes and find out what mutations are present. Do I care about 500? No, we don't have drugs for 500 genes, and we don't know what most of them do. But you know what? I don't care, because there's more drugs coming, and so the more knowledge, the better. But there's critical ones that we can find out that if they are mutated, that potentially we can have a drug to turn those off. Like a gene called KRAS. We've known about mutation in KRAS for like decades. And we just said no mutations usually because there's no drugs. Well, now there's drugs for KRAS. So it's important to test. So that's one type of biomarkers you can find. The other one that's actually more relevant to gastric cancer is when you actually don't have necessarily mutations, although you may have extra copies of the gene, but all of a sudden you have a ton of the same protein on the surface, and so we have a lot of it. All of a sudden it signals a lot more and drives the cancer cell to divide. And with regards to gastric cancer cells, HER2 is frequently overexpressed, so you have too many of this. And then there could be also other different markers. For example, there's the markers on a cancer cell that can attract the immune cells to come in and attack the cancer cell. Or there could be a markers on the cell that tells the immune cells to not come in. So there's other ways to look at what's present near the cancer cells. So now with that, let's talk about microsatellite instability. Microsatellite instability, you've heard this mentioned from Dr. Wu. Everybody says MSI high, patients respond to immunotherapy. So what is MSI high? So the way at least and I'm sorry if this is basic, but I think it's kind of important to review. So what is MSI high? So what I tell my patients that when we type on a keyboard and you have backspace keys, if you have a mistake, you can delete that, make that mistake. What in MSI high tumors, some of those backspace keys are missing. So that when DNA is being made, which is a compilation of letters, all of a sudden mutations accumulate. So MMR, mismatch repair protein, are those backspace keys. So we can check for those pretty quickly. If you don't have those backspace keys, all of a sudden your cancer has a ton of mutations, it looks off. Your immune system can recognize it easily because it's just like so off, has so many mutations. That's why immunotherapy can come in and help. Because immunotherapy doesn't really stimulate the immune system, it just helps the immune system. The immune system is already primed to recognize these cells because they look so off, and now so we can take advantage of this with the drug. There are genetic syndromes that run in the family that can predict or can lead to the development of these MSI high tumors. You probably have heard Lynch syndrome. And we see this a lot among patients with colorectal cancer. You know, in my experience, I don't see a lot of Lynch syndrome even in patients with MSI high tumors. It's important to consider genetics referral anyways to make sure if you see an MSI high tumor in a patient, we have to make sure that this is not related to something that can be passed down or something that runs in the family. These tumors, as Dr. Wu has already mentioned, may be more resistant to chemotherapy. Certainly in patients who have early stage cancer that we are thinking of surgery, we should not be using chemotherapy and we should be using immunotherapy. I have to say, in my patients who have stage 4 cancer, I still use both chemotherapy and immunotherapy because I think we need to use all the tools we have to slow down this disease and make sure that patients have responses quickly. So let's talk about immunotherapy. This is the cartoon. I did not make this one. As you can see, it's more fancier than mine, the cell. But this is kind of explains how immunotherapy works. So if cancer cell is in pink here, if the T cell comes to the cancer cell, says, I'm going to eat you or kill you, the cancer cell can basically say, whatever, I'm going to kill the immune cells. What PD-L1 inhibitors are, they basically allow immune cells to protect themselves from cancer cells, inhibiting them. So they don't stimulate the immune cells. They just help immune cells evade some of the mechanisms that cancer cells have to evade them. And so this is actually taken from the medical journal. So there's many different ways in which cancer cells or cells in a tumor environment can have a way to paralyze the immune system. And so you see PD-L1 and PD-1. So those are the antennas that basically when they bind, when the cancer cell binds to immune cells, the immune cell is not firing. So what immunotherapy drugs do, such as pembrolizumab and tislelizumab and nivolumab, they basically put those caps between PD-1 and PD-L1, so all of a sudden the mechanism is not employed anymore, right? So all of a sudden the T cell cannot be paralyzed anymore by the tumor cells. But a few things have to happen, which is why biomarker testing is so important. A, immune cells have to be there because they're not even around the tumor cell. You can block these markers till you're blue. Nothing is going to happen. The other thing needs to happen is those PD-1 antennas have to be there. Because if those PD-1 antennas are not there, you can block them, but if they're not there, the drugs are not going to work. Which is why we're talking about checking for biomarkers for immunotherapy in gastric cancer. Those are not great biomarkers, and if you come to any of the scientific talks, you'll hear people arguing, what's the right percentage of the tumor cells? What's the right test? But the bottom line is we should be checking for them. If there is no PD-L1, these drugs are not going to work. If there's at least some, and I use a cutoff of 1% in my practice, then patients should get access to immunotherapy. Why are we excited about immunotherapy? Because these agents help chemotherapy work better in patients with these tumors. Tumors shrink faster, they shrink more, and the shrinkage, I don't know if that's the word, but when they shrink, this response lasts longer. So the terrible numbers that Dr. Wu quoted to you, 2%, 3%, 5 years, I don't think they're true anymore. We are seeing more patients live longer, especially those that respond to immunotherapy, because these drugs provide more durable response. But again, for people to know that they qualify for these treatments, we need to check for biomarkers. And so all patients' tumors need to be tested, and people should be considered for these targeted drugs. There's a new drug on the market called zolbetuximab. I think we're all the way down to Z in the alphabet. This is why, the names start with Z. Could be worse. There's some worse drugs out there that are coming out. Zolbe is the shortened version. And it's a new biomarker. So I haven't presented in my prior slide, but I'll tell you about this biomarker here as well. So this is a new marker that we should be testing, and I am testing, and all of us should be testing our patients' tumors for. It's called Claudin 18.2. I can tell you, like 7 years ago, nobody knew what Claudin 18.2 was. Now there's, I think, over 30 to 40 agents in development going after Claudin themselves. So what Claudin is, I'll try to explain to you. So the cells, in normal organs, it's expressed only in stomach. So the cells that line the stomach kind of form a nice little column. Well, actually, I have a picture here. And Claudin is kind of in between, hidden away. You can't really see it. It's right there. When the cancer cells, when the stomach lining becomes cancerous, the cells become disorganized. And all of a sudden, you can see Claudin is exposed. So it's not that it's doing anything. It's just there so we can get there. So we can develop drugs that in a way, go to the right location. So zolbituximab is an antibody that binds to Claudin, and it has a way to kind of attract immune cells in there as well. And so now we know that if you add zolbituximab to chemotherapy in patients who have Claudin-positive tumors, people live longer. So this is the reason to test for these biomarkers. I think we need to be testing for all of these biomarkers at the same time. We cannot do this sequentially because we need to have all of this information when we see patients in clinic. So let me give you just a summary how I approach patients that I see in clinic and meet them for the first time. So all of my patients have all of these biomarkers done when I see them in clinic, or if they don't, we would see them within a few days of seeing them, because we need to find out how best to treat patients. And I tell people that everybody gets chemo. I'm hoping we'll get to the point where we will start to take away drugs. Right now, we still add drugs. Everybody gets chemo. We tried omitting chemo. People don't do as well. And that's because people who come to clinic have so many symptoms. I see a lot of patients with gastrointestinal junction tumors, so people can't swallow rather than true stomach cancer. So it's important to give chemo. And then we add drugs depending on what markers they have present. And the way I think about it, for chemotherapy, usually we give FOLFOX, although you can use other drugs, but FOLFOX is our go-to. I add immunotherapy, and we have 3 drugs now approved: nivolumab, tislelizumab, and pembrolizumab. And then depending on whether the patient has a HER2-positive tumor, we add trastuzumab. If they have, and then also you can combine trastuzumab with immunotherapy as well if they have both PD-L1 and HER2 positivity. And then you can add zolbituximab if they have Claudin, if the tumors are Claudin positive. So you need to have all of that information to pick the right treatment. I have this here now. So HER2 positive, chemo plus HER2 plus pembrolizumab, PD-L1, CPS1 or greater. HER2 negative, if PD-L1 negative, only chemotherapy. PD-L1 positive, immunotherapy and chemo. And then for Claudin positive, chemo and zolbituximab. The issue is, and this is what everybody asking, like in a scientific method, well, how are you going to figure out which drug to use if there's more than one target? I think from the patient perspective, good problem to have. The more drugs, the better. Everybody will have different tolerance. But we will have to figure out how to combine these drugs and how to sequence them. Because if you look at the percentages of each positivity, it will end up to more than 100%. And so the reality is what people are doing now is they're doing combination studies. They're doing chemo plus immunotherapy plus a targeted drug, combining more. I mean, at some point, there will be too many drugs to combine, and then we'll do some fancy combination, antibody-drug conjugates, bispecific, et cetera. I'll show you some of that information. But we also will have to take into consideration, the degree of positivity. What if this one is 90% and the other one is 2%, right? That's probably will go up to the 90%. Side effects will matter as well. Also, if you, for example, use immunotherapy in patients with early, incorporate them earlier, then certainly you would want to switch to a different drug if we need to. But all of that, we are still all trying to figure out how to do it. But that is not the reason not to test for all of them. There is still a reason to get all of this information ASAP. So what are the updates in second-line treatments? There hasn't been that many updates here. I think the newest drug probably here is trastuzumab deruxtecan. About 15% of patients' tumors have HER2 positive. I've talked about HER2 earlier. And it's important to test for HER2 more than once, because if people have HER2 positive disease at the beginning, when the tumor starts to grow, one of the reasons it can grow is because all of a sudden it's like, oh, whatever, like I'm going to lose HER2 now. So, I can develop a new mutation. So it doesn't make sense necessarily to go after HER2 in second line. So it's really important to check over time to make sure that it's still HER2 that's driving the tumor growth. The new drug, or it's not that new anymore, but relatively new drug that's been developed, been approved for HER2-positive gastric cancer is trastuzumab deruxtecan, and it's one of those hybrid molecules that has an antibody. The antibody portion of this drug is where it binds the same place that trastuzumab binds, and then it brings with it chemo. So I tell my patients it is targeted chemo. And so this is the drug that we can use in second line if tumors continue to be HER2 positive, even when it's, after it starts to grow on treatment with trastuzumab and chemotherapy and Keytruda at the beginning. So what's on the horizon? I think the one new biomarker that's important to before we go there, this is the question that people ask a lot. Why can't you just cut it out, right? You just heard from Dr. Wu. Even if people have stage 4 disease, we all get asked, well, can you just take it out? And this is the research that's kind of close and dear to my heart because I'm doing a study looking at patients with oligometastatic disease. So stage 4 could mean many different things. Stage 4 means, that I explain to my patients, that the cancer cell was able to get into the bloodstream and travel to other places and seed other organs. That's stage 4. But stage 4 in somebody who has 1 lung spot and somebody who has 15 liver spots, that we don't differentiate. We treat them the same. So the question is that maybe we need to be more aggressive in patients who have this oligometastatic or limited number of metastatic spots. And rather than surgery, I think radiation actually provides a good alternative to surgery, because it's hard to take out with surgery multiple different spots from different locations, and to undergo a big surgery, you need to stop treatment. You need to stop treatment that's actually working. And so radiation, I think, provides a good alternative to surgery in patients who have metastatic disease with small number of spots. And so we are running, this is an NCI-sponsored clinical trial looking specifically at the role of radiation for patients who have limited number of spots. So if somebody comes in and they have 1 liver spot and 1 lung spot and have a great response to chemotherapy and immunotherapy, the question is, well, maybe we're not doing enough actually with chemoimmunotherapy. Maybe we need to go and radiate with high dose of radiation what we can see, and then continue in chemo and immunotherapy. I tell patients in this disease, with this disease, that I would never start with radiation or surgery at the start, because what I'm more worried at the beginning is about what I cannot see. And what I cannot see is the cancer cells that are circulating through the bloodstream and trying to seed other places. But if nothing is growing 3 to 6 months and I still cannot see things anywhere else besides the 2 spots, I think this is a study to consider and to ask a question whether we can be more effective at treating these patients with local therapies. So let me talk about some of the newer biomarkers. FGFR2b, this is an emerging biomarker, so we didn't make it in the earlier slides because we don't have an approved drug yet, but we are excited because there is a drug in development for this marker, and we've seen some promising signals already. FGFR2b, it's another one of those antennas on the surface of the cancer cells that if there's a lot of it or it's expressed at a higher level, maybe we can target it. Up to 30% of patients can have this biomarker that's expressed to a higher level on their cancer cells, and about 15% of patients have it expressed at even like higher level, where we see more signal with a drug called bemarituzumab. And so it's not ready for prime time yet, but bemarituzumab is an antibody for FGFR2b that showed some good activity in phase 2 studies. And so now there have been 2 phase 3 studies that are I think, completing enrollment, and we are waiting for data that looks at the addition of bemarituzumab to chemotherapy or chemotherapy and immunotherapy in patients who have the particular biomarkers. So yet potentially another way to personalize care. The other thing to be on the lookout for is all these new drugs that are going after claudin. I mentioned claudin, how it's not really it's not really making the cancer cell tick per se, but it identifies or tells us where the drugs can be directed to. And there's an explosion of drugs that go after clot, and maybe we can use them sequentially if they work. There's some targeted chemo, there's some cell therapy, there's bispecific antibodies. You mean the antibody bites the clot, and then the immune cells bring them together, all kinds of drugs in development, and we are seeing promising activity. And then the other, speaking of bispecific antibodies, I want to mention the other new drug that goes after HER2. So this is a bispecific antibody called zanidatamab. It's not bispecific in a way that it binds to the cancer cells and immune cells. It doesn't do that. It binds to the cancer cell of HER2, the one antenna, in 2 different locations. And it's a pretty interesting drug because it's already approved for biliary tract cancers. And what's incredible about this drug, that it's an antibody. It has no chemo, so it's not targeted chemo. It's just an antibody. Well, it's not just an antibody. It's a bispecific antibody that by itself was able to shrink tumors in more than 50% of patients with bile duct cancers with HER2-positive tumors. And has this antibody, in combination with chemotherapy, has shown very promising activity in gastric cancer as well. So now we are waiting the results of the phase 3 trial that tries to basically, it kind of looks much better than trastuzumab. Like if trastuzumab would not shrink bile duct cancers, like there's no way. And so hopefully we will see that we'll be able to incorporate this drug for patients with gastric cancer as well in earlier lines. And we're waiting the results for this study. Another, just to mention, because I'm trying to mention some of the phase 3 trials. The trials, if these phase 3 trials, meaning if they're positive, they can change the way we treat cancers. They're not these like exploratory, 20 patients here and there, and like we see a signal, we get excited. These are placebo-controlled or controlled clinical trials. The other one is STAR 221. And this is a clinical trial that looks at the addition of 2 immunotherapy drugs to chemo. Domzim. They have full names, but we'll stick with Domzim right now. But anyway, it's just something to look for. There's no results yet, but the potentially another study that may change our standard practice. So many different research, many novel agents, many strategies, and again, I can't drive this point home enough. For us to be able to utilize these new drugs, is us as medical oncologists, we need to make sure that we know as much as we can about patients' tumors, but also about patients' goals, patients' families, patients' CT scans, patients' kids, everything. I think we're not just treating the tumor, we are treating a patient. I tell my patients all the time, there's a textbook version of things, and there's a real life version, and you need to be aware of that. So thank you. Thank you all so much. Thank you for the invitation, and happy to answer questions. Okay. So I'm going to sit down, and I'm going to introduce, but before that, I'll introduce our next speaker, Dr. Rita Mukherjee. Dr. Mukherjee is a medical oncologist specializing in the treatment of gastrointestinal cancers. Her research interests involve GI cancers, novel drug development, predictive and prognostic genomic biomarkers, including circulating tumor DNA. I didn't talk about it at all in my talk, but I think she will have some pointers about that. She has published several peer-reviewed journal articles on the role of immunotherapies, applications of prognostic genomic biomarkers, and applications of liquid biopsies in the management of patients with gastrointestinal cancers. And she also has a special interest in upper GI tumors. She spearheads Beth Starr Georgetown's clinical and research endeavors. And so please, everybody, welcome Dr. Mukherjee.
All right. Can everyone hear me okay? All right, thank you so much for inviting me. It's really an honor to be here to present to you guys and follow Dr. Uboha's great presentation on biomarkers. So I'll also discuss a little bit about biomarkers, precision medicine, how we can incorporate them in a multidisciplinary care, and touch a little bit more on liquid biopsy, which we may not have heard about as much in the previous lectures. So these are my disclosures. So going into biomarkers, I think you may hear a lot of overlap with some of my talk compared to what we heard with Dr. Uboha, but it's really to kind of double down on the importance of understanding what they are and which ones especially are important to check up front now. So What are biomarkers? They're genomic signals, proteins, or gene, protein, or molecular signals that essentially characterize disease. And they're important because they can help in diagnosis, prognosticate, predict responses to treatment, and really personalize the care of patients with cancers, including GI cancers. So again, as an example, our frontline treatment for patients with unresectable advanced metastatic stomach cancer really is that backbone chemotherapy, often a combination of drugs called FOLFOX or CAPOX, and to it we add targeted therapies based on the presence of certain biomarkers. So kind of diving in again to what we heard about before, one of the major ones we must test for up front is microsatellite instability status or mismatch repair deficiency. So very simply, this is a measure of how well the tumor cells can repair alterations or mutations in DNA damage that occur during the replication process. So if tumors are lacking in the machinery that help repair DNA, they accumulate a lot of mutations, like Dr. Oboha mentioned. Cancer cells look very abnormal. There are a lot of abnormal proteins. They're better recognized by the immune system, and that's why we think immunotherapy, which help augment the immune system's ability to attack cancer, work well here. So for patients with mismatch repair deficient or microsatellite unstable tumors, we really should be adding immunotherapy to chemotherapy up front. It's not to say that those that don't have that status shouldn't receive immunotherapy. There are other markers that we look at to help determine who's likely to benefit. PD-L1 is that other marker that we discussed briefly. This is a protein that's expressed on the surface of a tumor cell. And as mentioned before, I kind of think about it as a don't kill me signal. Cancer cells put this protein up and it's able to hide from the immune system. And immunotherapies are drugs that go and bind and block that don't kill me signal, unmasking cancer from the body's immune system so the immune system can target it. We can measure the expression of PD-L1 on tumor cells and immune cells by protein staining on tumor biopsies. We think the more PD-L1 expression, the more likely immunotherapies are to work. And so as mentioned, we do look for at least some expression of PD-L1. We think higher numbers mean immunotherapy works better, and different thresholds are used, 1 or even above 5, in making determinations of who may benefit from adding immunotherapy. Pembrolizumab, nivolumab, and tislelizumab are the 3 immunotherapies that we have approved today that we can add in addition to chemotherapy. The next biomarker is HER2. So again, this is also a membrane receptor or a protein that can be expressed on the surface of cells. And some cancer cells have very little to no HER2 expression, whereas other cells can have a lot of HER2 protein expression on the cell. And for patients, about 15 to 20% of stomach cancer patients may have overexpression of HER2, and these patients may benefit from the addition of HER2-directed therapy or antibodies that target and block HER2. And for example, trastuzumab was approved in October of 2010 when added to chemotherapy, improved response rates, and improved survival. We've also learned more recently that if you express HER2 and PD-L1, you benefit from the addition of trastuzumab and immunotherapy to chemotherapy. So now especially understanding the presence of both biomarkers are important to optimize the frontline treatment. Claudin 18.2 is really the new kid on the block. Just recently, as Dr. Oboha mentioned, in October 2024, we had a new approval for a drug targeting Claudin. So this is another protein that can become aberrantly or abnormally expressed on the surface of cancer cells, and we can target it with antibody drugs like zolbetuximab, which was approved, improved survival compared to chemotherapy alone, and this was just approved. We do think that some of these drugs work better when there's higher expression of that marker. There's more targets, so more efficacy. So right now, this drug is approved for patients who have moderate to strong expression of this protein on the majority of their cancer cells in a biopsy specimen, so 75% or more of cells. So all of these markers are so important to help us determine the frontline treatment. We talked about mismatch repair, HER2, PD-L1, and now Claudin. These are markers that you should ask your medical oncologist and make sure they're tested up front, especially if you have advanced or metastatic disease. But understanding these markers and others goes beyond just the frontline therapy. We know that about 30-40% of patients, even with these drugs, may not have the responses that we want to see from therapy. And at the time of progression, when we need to be thinking about the next step, there are other drugs that are also targeting some of these markers that we want to think about if these tumors have certain biomarkers. So for example, we alluded to briefly on CAR T cell therapy before. This is a different type of immunotherapy. It's when we take immune cells from a patient, collect them, and then we engineer them or reprogram them to target a specific marker, for instance, claudin. And then we amplify them in the lab, and then we deliver them back through an infusion to the patient to go and attack the cancer cells. So this, for example, this strategy has been used in patients with claudin-expressing tumors, claudin 18.2, and we've seen some promising results using this CAR T therapy, with response rates in over 50% of patients and 3 out of 4 patients having stable disease or shrinkage of tumor. So very promising results, and strategies like this are undergoing further investigation. We talked a little bit about bispecific antibodies. So these are other drug approaches that are designed to try to overcome some of the limitations of our current antibody drugs. So for instance, one thing to appreciate is that cancers are quite heterogeneous. In one ball of cancer, it's made up of millions of cancer cells. But all those cells aren't the same, and they may not all express the same amount of a certain protein or a marker as a next door neighbor. So for example, you may have some cancer cells in the olive color here with the red triangles that express a certain marker, but right next to them you have cancer cells that don't express them, and these are able to evade or bypass some of our targeted therapies. So antibody drug conjugates are like antibody drugs. They find a target, they go to it, but they're unique in that they are coupled or bound to chemotherapy, kind of like a targeted bomb, if you will, and it takes that drug right to some of these cells that express this marker. But then at the site of the cancer, it disseminates that chemotherapy that can be taken up into some of the nearby cells that may not have the marker. And this is called bystander effect. And we think we can kill more cancer cells in an area, even those that don't express a marker. So this has also been evaluated, trastuzumab deruxtecan, that has been discussed before as an example of an antibody-drug conjugate. And certainly we've also now been looking at antibody-drug conjugates to target claudin. For example, this is an antibody-drug conjugate targeting claudin that was evaluated in patients with claudin-expressing cancers. And we see, again, some promising response rates, 35, but almost up to 50% in patients at certain dose levels of a drug with good disease control. And this, for instance, this compound right now is undergoing further investigation in a trial called the Clarity Gastric 01 trial, looking at this agent combined to standard of care chemotherapy in patients who have progressed on frontline or second-line therapies. So again, many ongoing trials looking at novel agents, different immunotherapy targets. For example, Dr. Uboha commented on STAR 221. I also included here as it's a very important trial looking at targeting different immunotherapy markers, not just PD-1 or PD-L1, but also another don't kill me signal called TIGIT. There are also some promising trials like the Distinguished trial looking at drugs that target another marker called DKK1, and we think by binding to this and giving immunotherapy, we may increase the efficacy of certain immunotherapies. And there are other trials, Fortitude studies 101 and 102 that were briefly discussed before as well, looking at other novel upcoming biomarkers like FGFR2b. So we know that it's important to test, not just for frontline, but for subsequent lines of therapies. How exactly do we test? So it's really a combination of testing on the tumor protein staining. We also can test for the expression of certain genes at the level of the DNA with technologies called in situ hybridization. And then we can also actually analyze the building blocks of the cancer cells and the programming in the DNA and the RNA. So oftentimes this can be done with simple tests that we send off in our own institutions, but many times we're sending broad panels to companies such as Caris, Foundation One, Tempus, where hundreds of genes are analyzed, and at the same time protein expression and gene amplifications are tested using various methods. So we can test the tissue, but we are also learning in the past few decades, liquid biopsies or testing for these alterations in the blood is becoming an especially important strategy that may be able to complement or overcome some of the limitations of tissue-based testing. So what is liquid biopsy? When we talk about this, I'll really refer to cell-free or circulating tumor DNA. So a concept to know is all of the organs in our body, our heart, our kidneys, all of them are made of cells that have DNA that program them to tell them what to do. And our normal organs and our normal cells can spill their DNA into the blood, and this is called cell-free DNA. But tumors, which shouldn't be there, but tumors also have DNA that program it, tell it to grow, and they can spill DNA into their blood as well. And so through a simple blood draw, we're able to capture DNA from our normal cells and circulating tumor DNA as well. There are some characteristics of circulating tumor DNA that allow us to identify it as different from normal DNA. They tend to be shorter in size. They tend to have tumor-specific alterations. Many potential applications of circulating tumor DNA in the management of cancer. Through a simple blood draw with further testing, can we use it to screen very early signs of cancer? For patients who are undergoing perioperative therapies, can we use it to understand who's responding or not to treatment? For patients who undergo curative surgeries, can we use it as a marker after surgery to see if there's any residual cancer? And for patients who have measurable metastatic disease and we start them on treatment, can we trend the circulating tumor DNA levels using simple blood draws to understand if there's response to therapy or identify emerging resistant mechanisms? So there are some fundamental differences between tissue-based and blood-based testing. Tissue testing, of course, requires a biopsy, so you need a surgical specimen or a prior biopsy or a new biopsy through a procedure. Tissue biopsy is characterizing just one site, one tumor in one location. And the turnaround time for these broad panels used to be on the scale of 4 to 6 weeks, although we are seeing that these results are coming out quicker and quicker, even up to 2 weeks in some cases. On the other hand, ctDNA or liquid biopsy can be done through a blood draw. It's non-invasive. The thought is that we know, again, as I mentioned, not all cancer sites have the same genetic alterations or DNA, and since all sites of cancer theoretically can spill that DNA into the bloodstream, with one blood draw, you might capture genomic heterogeneity or multiple characteristics of multiple sites of cancer in a blood draw. And the turnaround time tends to be shorter with blood-based testing, 7 to 10 days. However, the amount of DNA captured in the blood is much less than that picked up in tissue, so there are some limitations we need to be aware about, and there are some sensitivity limitations with using blood-based testing. So if you don't find something in the blood, it does not always mean that it's actually not there, and we still often use tissue testing to complement. Many studies have looked at how well circulating tumor DNA works. Can it pick up the same things that tissue does? And across trials, we've seen fairly high concordance rates across matched samples, meaning in a patient you had a blood draw, you had tissue, and you saw which mutations overlapped, as high as 80, 90%. But certainly there are some discordance as well. So again, highlighting that tissue-based testing may not always pick up what's in the blood, and blood may not always pick up in the tissue, but used together, they may be helpful. So I think, today, it's still very important to do tissue-based testing, but if you don't have access to tissue, if tissue has been exhausted, or if a patient feels a biopsy is too high risk or desires to not undergo a biopsy, doing a blood test in the clinic to try to, as another means to find some of these genetic alterations can be very helpful, and sometimes even in conjunction with tissue-based testing. Can we use these tests to predict who's likely to benefit from some of these targeted therapies? So we look at some data from trials in what we call post hoc or subgroup analyses, and the answer may be yes. There's still some more research that we have to have in this space. But for example, the Destiny Gastric trial was a study that looked at trastuzumab deruxtecan in patients with HER2 amplified disease. And when we looked at patients who had blood testing done, those who had HER2, the target, amplified in the blood, and especially at high numbers, those patients tended to have higher response rates than those that did not have the marker or much lower expression. And very similar patterns of benefit were seen in the study called the FIGHT trial, which looked at bemarituzumab, a drug combined with chemo that targets FGFR2b. And in patients where the FGFR2b amplification was detected in the blood, they had much higher rates of risk of reduction for cancer progression or death compared to those where the marker was not identified. So again, it could potentially be used as a predictive marker for the benefit of certain therapies. ctDNA also can help us identify emerging resistance mechanisms to treatment. For example, if you have a patient who this is a patient who was on HER2-directed therapy, and what you see here is a diagram where all these colors represent different genetic alterations that were picked up on a blood sample. They were treated with therapy, and you see that these mutations decrease at the same time they had a response, meaning cancer shrinkage, on the scan. And then at the time when the cancer started to grow again, you do another blood test and you can identify new mutations that are emerging at the time of cancer progression. And for example, in this patient, they had emerging MYC and MET gene amplifications, which may be mechanisms by which the cancer cells are becoming resistant to HER2 therapy. And so I think, using these blood tests can help us identify mechanisms of resistance and maybe also be used to personalize care in subsequent lines of therapy when we identify other mutations that may have targets in the future. We also know that the ctDNA kinetics, or the trends of ctDNA in treatment, can be informative on the benefit of therapy. We know that for patients where if you start therapy and then you trend the ctDNA, whether you do a blood test and a few weeks later you do another blood test, patients who clear ctDNA or the value of ctDNA drops, they tend to do better in progression-free and overall survival compared to those who don't clear. So can we use this as a marker to identify earlier on, rather than waiting 3-4 months for scans, who's benefiting from a therapy and potentially spare people toxicity when not needed? So these are kind of some of the things we're thinking about in our community about how we can use this test in the future, and of course need to validate it further in other trials. So how can we apply some of these biomarkers in the perioperative setting? We talked a lot about advanced disease, and just to kind of summarize again what has been talked before by Dr. Wu, for very early stage stomach cancer, surgery alone is a standard of care. But for locally advanced disease where there's more invasion through the wall or lymph node involvement, we're often recommending chemotherapy before and after surgery, and this is usually with the FLOT regimen, 5-FU, oxaliplatin, and docetaxel, 4 cycles before and 4 cycles after surgery. We look at a biomarker in our clinical trials called pathologic complete response rates. And what that is after you receive chemotherapy and at the time of surgery, we look at that tissue that's been pulled out and we see, is there any cancer cell left behind? And in trials with this chemotherapy, in general, the path complete response rates after chemotherapy is around 7 to 15%. Now, while FLOT is used in the majority of patients, microsatellite instability or mismatch repair deficient tumors we talked are very different biology, and they may not respond, they don't respond as well to chemotherapy in the perioperative setting. So historically, we recommended these patients go for surgery first. But there were 2 phase 2 trials, meaning these were small numbers of patients that were enrolled, and they received immunotherapy, not chemo, but immunotherapy before surgery. And then they went for surgery, and we actually saw much higher path complete response rates, around 60%, compared to 7 to 15% we see with chemo. So, and with follow-up, albeit understanding that it's short follow-up, we've had very low rates of recurrence. And so immunotherapy really should be used in these patients up front now prior to surgery. And that's why I think, just to underscore the importance of testing for MSI high or mismatch repair deficiency in any stage of cancer is so important today. What about the 90% of patients who don't have microsatellite instability or mismatch repair deficiency? Can we use immunotherapy? We've seen immunotherapy added to chemo improve survival in metastatic disease. Can we move it up to the perioperative setting? We've had 3 major phase 3 trials that have compared chemo versus chemo plus immunotherapy, and what we've learned is that path responses improve, so the responses tend to be better, but we have not yet seen a statistically significant survival benefit in our trials. For instance, we had one trial that read out that unfortunately there were trends for improved survival, but it wasn't statistically significant, won't lead to an FDA approval, but we are awaiting the results of 2 other trials using different immunotherapies, and so more to come in this space. But today, unless you have microsatellite instability or mismatch repair deficiency, chemo still remains the perioperative treatment for most patients. How about HER2 therapy? Again, 15 to 20% of patients have HER2 amplified disease. Should we add trastuzumab or HER2 therapy to chemotherapy before and after surgery? Actually, just a month and a half ago, we were at our conference in San Francisco, GI ASCO, and results from this trial, the innovation trial, were presented. And this looked at chemo versus chemo plus trastuzumab versus chemo plus trastuzumab and pertuzumab, another HER2 targeted therapy. And again, while there might have been signals for better responses, unfortunately, it didn't show a dramatic improvement in survival. So while this may not move forward, I think this opens the door to look at some of these other therapies, zanidatamab, like we mentioned, or other novel HER2-directed therapies to see if we can improve the outcomes in these patients. And in fact, there are ongoing trials looking at combining combining chemo, HER2-directed therapy, trastuzumab, and immunotherapy before surgery, the FERFLOT trial, and then another trial looking even at trastuzumab deruxtecan in combination with chemo and immunotherapy in different treatment arms. So more to come in this space as well. And finally, ctDNA, can we use this in the perioperative setting? And I think a multitude of studies across GI cancers, not just stomach cancers, have shown that the detection of ctDNA after surgery is highly prognostic. That means it can be very informative and risk stratifying who's likely to relapse versus who's not. And we've seen in trials that patients, if you have no ctDNA detected in a blood draw after surgery, these patients tend to do better in the way of less relapse compared to if there is ctDNA detected. And we've seen across trials that sometimes the detection on a blood test can predict relapse on a scan even 4 to 9 months in lead time compared to when relapse is detected on a CT scan. So it can identify very, very early signs of relapse. So again, today, for majority of patients, we give chemo, surgery, chemo, and then we do wait and watch with active surveillance. We do CT scans, clinic visits. This may be every 3 to 6 months based on the stage. And we don't treat until we see cancer actually come back on a scan. That is the standard today. But what if you have someone whose scans look good, you don't see cancer, but their microscopic ctDNA blood test comes back positive? This is a very high-risk patient where we know that this patient is, eventually going to relapse. It may be a few months from now, but what do we do? Do we give them treatment? Do we wait for something to come back? I do think, we are identifying this as a new stage that we weren't previously able to identify, microscopic residual disease. And there's no FDA-approved treatments in this space, but certainly a group of patients where we should be developing trials to look for novel therapies to potentially eradicate ctDNA, try to increase the rates of cure, and improve survival for more patients. And so, we are hoping to see more randomized trials in the future using ctDNA to guide escalation or even de-escalation approaches for some patients. And one day, if we could validate ctDNA clearance, something you can capture within just a few weeks to months as a surrogate for survival, we may be able to facilitate more timely drug development in the adjuvant setting rather than waiting for years for some of this data to play out. So a shameless plug for just an example of such a trial, we have a pilot feasibility study at Georgetown that I wrote in conjunction with Dr. John Marshall, my mentor, where we're identifying patients, GI cancers who've undergone all curative therapies, have no evidence of disease on scans, but a positive ctDNA test. And we are enrolling patients and trying to treat with immunotherapy, atezolizumab, and anti-VEGF, or another agent that enhances immunotherapy efficacy, bevacizumab, and looking for ctDNA clearance. And can we find and enroll patients in this setting? So it's a feasibility study, and we hope to see more like this. And certainly there are more coming out across the country. And then very briefly, kind of alluding back to Dr. Wu's talk, she talked about, at the time of diagnosis, it's very important to do a diagnostic laparoscopy to help with proper staging. And often what a surgeon will take a look in with the camera, draw some fluid, and look for cancer cells in the fluid called cytology. However, we know that cytology is not perfect. It can miss 40 to 50% of patients that actually have cancer in the peritoneum if it's just very, very small amounts. So I think this is another area where we can do more research and try to find more enhanced biomarkers to detect occult disease. And the question is, can we use some of these technologies like cell-free DNA instead in conjunction, maybe not replacing, but in conjunction with cytology to better risk stratify and stage people? So overall, I think, gastric cancers have a lot of targetable alterations now, more than we did a few years ago. It's a very complex field now, but I think it's a good problem to have. We have more options. I didn't go into all the details with this, but even ctDNA, there are so many tests, so many companies out there, different ways to test ctDNA. We have a lot of options in our hands now. It's about putting it together and finding the best way now to use it for our patients. So I think, the future is very exciting, a lot of advancements, and we hope with further research in some of these biomarkers, novel biomarkers, and how to best use circulating tumor DNA, we can help improve the outcomes of more patients with GI cancers. Thank you.
Thank you so much, Dr. Mukherjee. This was a great talk and a great summary of what we know right now about ctDNA. It's an amazing tool, and We're all still learning how to use it, but I think it's going to be instrumental in both picking the right treatments for patients, but also to expedite the way we develop drugs. But I would like to invite Dr. Taylor as well to join us on stage right now. Dr. Taylor is a practicing pathologist at Mass General Hospital, so he will tell you the truth about biomarkers, the true facts, away from our cartoons. And he is an instructor of pathology at Harvard Medical School. His research focuses on the fundamental mechanisms of the human line 1 retrotransposon. Did I say that correct?
Yeah, I'll talk about what that is later.
Its impact on cellular function is potential applications in cancer diagnostics and therapeutics. Dr. Taylor has been instrumental in developing tools to study line 1, identifying key cellular interactors, and establishing line 1 ORF1p as a promising multi-cancer biomarker. His work has led to generation of widely used line 1 affinity reagents and significant insights into line 1 ORF2 structure. You'll learn about this later, I assume, and function. He's supported by KO8 from NIDDK, Dana-Farber Harvard Cancer Center, and Stand Up to Cancer. And he continues to drive groundbreaking research at the intersection of cancer biology, molecular pathology, and translational medicine. Welcome, Dr. Taylor. Thank you. And we'll be happy to take questions. So please raise your hand so that we can give you the microphone. Thank you.
Mic test. Okay. So I have 2 questions for you. The first one is about the difference in nuance between the PD-1 and PD-L1 inhibitors. So what I thought is that if the PD-L1 score is high, it would be more efficient since the tumor cells would have more of the PD-L1 to target with the PD-L1 inhibitors, not the PD-1 inhibitors. So there are, drugs like durvalumab that we are using in pancreatic cancer. So I would like to be informed about the nuance of using PD-1 inhibitors versus PD-L1 inhibitors. So my second question is about peritoneal metastases. So like we do blood culture tests, like routine blood cultures to rule out infections, sepsis, those kind of things. I thought it might be eligible if we have a routine peritoneal fluid culture of cancer cells to check if cancer cells could grow. Would that be? I would like to question if that would be an appropriate or possible approach.
I can start, I guess. So the first question on the PD-L1 versus PD-1, from a testing perspective, PD-L1 is the part that's on the cancer cells, so that's just what we stain at the tissue level. As far as which one works clinically and which combinations, some of it is just kind of a dice roll. I think as to what people had actually tried in a trial, so that we know it works in a particular application. Although there's some real nuance that maybe the others here can speak to. As far as the peritoneal sampling, it's a super great idea. We are working on this from a research perspective, as are many other groups, both growing the tumors there and looking for better ways to detect whether there are trace amounts of them there. And I think that's what was just on your slide, just at the end. So it's a really interesting place to sample, and many people are also interested to see if we can, for example, take those cells and then put them through a bunch of different drug regimens to see what were we going to do next. Right now, this is all proof of concept and not yet mainstay, but there are things people are working on.
Yeah, I think, just regarding your first question, I agree. PD-L1 is usually what's expressed on the tumor cell. It can be on some of the immune cells, and PD-1 can be expressed on some of the immune cells. And I think what we've seen generally is, many clinical trials across tumor types have looked at PD-1 inhibitors and PD-L1 inhibitors, and they all kind of work by a similar mechanism, and so I agree with you. It's kind of a toss-up which one may, work, and sometimes these are used interchangeably and with similar efficacy across tumor types. And regarding the peritoneal fluid, I think that is an area where we've had some really great talks actually about a month and a half ago at GI ASCO about peritoneal disease. We need better biomarkers here to identify who has disease, who doesn't, even for patients who might be eligible for some of these bigger surgeries like HIPEC and cytoreduction in the future. And there are some inherent limitations to cytology. So there's not a lot of data that I've seen out there with cell-free DNA. There are some labs that have looked at it in the peritoneum. There's promising sensitivity. So this is certainly an area that I think warrants further investigation and a lot of promise for better biomarkers in the peritoneal fluid.
We have our favorite biomarker, which I'll talk about later, but I think as far as the PD-1, PD-L1, which one, when, the biggest question in oncology really, since immunotherapy showed that it could work much better than regular chemotherapy in some contexts, is how do we figure out who it works in, who it's going to work in, and how can we make that number of people a bigger piece of the pie, right? How can we make it just work in everybody? So there are about 1,000, maybe 3,000 trials, I think, the last I checked, that were all some immunotherapy plus some other thing, or some immunotherapy plus some other immunotherapy in some combination. And we're getting better after many of these trials at figuring out what order and which ones to give. But still the response rates are well under, depending on the tumor type, well under 50%. And the durable response rates are less, right? So we want it not only to work, but we want it to cure the disease. And then we wouldn't all be here. That would be great. So to get there, it's a bit of a road, right? And so those are the biggest questions, I think, that everybody's looking for. The biomarkers, right? How do we predict from the biomarker who's going to respond? Can we figure it out if they responded earlier? So those are all the still unanswered questions, I think, although we know some. Obviously, if you're MSI, then you're a very lucky person. Having been very unlucky, you're then in the lucky group of the unlucky, right? And so that's a start. But we'd like to get the response rates for people who are not MSI to match the people who are MSI. And then we'd like the response rates for the people who are MSI to be durable and actually be curative. So that's the task we're facing. Does that make sense?
Hi, when they do the pathology report, when they take your biopsy from your stomach, how do I know, or how can I be reassured that the pathologist runs everything from A to Z and they don't miss it? So when I get my pathology report, I don't see HER2. Does that mean they didn't run it? Did they forget it, or was it just negative, or that, or was it overlooked? And with that, what would be the difference between your lab work biomarkers, such as your CEA, your CA19-9, and all of that, as opposed to your cytology, peritoneum, washing, biomarkers? I mean, I look at my biomarkers, I don't see them running everything when I have my labs done. My labs are done every 21 days, and all I always see is CA19-9, CA129, CEA. How come I don't see everything else? Or what's the difference, or should they be running that? Multiple questions, sorry.
Well, I can start as the pathologist. So when the tissue comes out the first time, when there's a biopsy, then for a new diagnosis, then essentially the whole suite should be run. Exactly which of those are run will be institution dependent. And so it should be PD-L1, HER2, some places run EBV, and then Claudin 18.2. Right? So that's the suite that we usually run up front. But it'll depend a little bit on where your biopsy is taken and how much tissue there was. And of course, if it's not cancer, then there's no sense in running those things. Then the question is, once those statuses are determined on an initial tissue sample, does that make sense? Is it cost effective? And would it change your care to repeat those on a subsequent tissue sample? And then there's the bigger question, is the initial call on the biopsy correct? And is the staging correct? So if you presented in New York and you went to Sloan Kettering and had a nice workup there because it's a fabulous hospital, it would almost certainly be right. But if you then went to Boston and came to Mass Gen or came to us, I've just moved in the last year to Providence. I'm at Brown now. And you come to us there, It's okay. I think I forgot to tell Aki the updated.
I'm much better about tumor markers.
No, you did great. It was lovely. I really appreciated it. But if you then go to Mass General or any other cancer center, by default, your entire pathology is reviewed. So we will request, and every cancer center should request this, and everybody who has never had this done can always just request that their pathology be reviewed by an outside pathologist. And unlike radiology, that's actually paid for by Medicare, right? So everybody recognizes that pathologists are human and that if there's something wrong on the pathology report, it's going to have a big consequence. So because usually it's not wrong, 99 point something percent, 90 plus percent of the time, the pathologists are very careful, and we're very careful to be sure that if we even think there's a chance that we're wrong, we show it to another pathologist. That's all standard practice. Because often there is no second check, right? And everybody is terrified in pathology of missing something and making the wrong choice. So therefore, there's consensus conferences. There's a lot of safeguards in place to make sure that doesn't happen. But it still happens. So to advocate for yourself the best you can and for the people you care about, external review is a good idea. So then I think that maybe the oncologists can answer a little bit better. Maybe you have a better sense of when you retest, because those levels in your fluid are more about how much tumor is still, about tumor burden than an intrinsic property of the tumor, which is one of the things that we're asking with a lot of the stains. Does that make sense?
How are the biomarkers different when they draw your blood? They're like, oh, we're going to be drawing your biomarkers.
Can I tell you, I don't check those in my practice. I think the biomarkers, the blood-based CEA and CA99 are useless in gastroesophageal cancer patients. We never make treatment decision based on these markers. If anything, they create false reassurance or frustrations. They're much more useful in patients with CA99 is much more useful in pancreas cancer and CEA and colorectal, but I don't check.
How often, which biomarkers should we be getting? Which biomarkers should your doctors be ordering, and how often should those biomarkers be?
There's no good liquid biomarkers. I think you're asking questions. We may be confusing two different markers. There's a way to characterize the tumor, the stuff that's present on cancer cells.
Yes.
Those are markers like HER2, PD-L1. That's done at the time of diagnosis. Sometimes it's not done if somebody has very early stage cancer, and you might not have had HER2 or PD-L1 at the time of surgery because that's not standard to test those in patients with early stage cancer. So that may be why pathologists haven't done it. And then there's markers like tumor markers, and that's something that's cancer cells secrete in the blood. And while, at least in my experience and in my practice, I do use those for patients with colon cancer and pancreas cancer, I do not think they're very helpful in patients with gastroesophageal cancer. So I do not test those, CEA, CA99. That's something that cancer cells secrete. They don't tell you how to treat cancers. All they can tell you, if it's negative, that's great. But they're not reliable.
So the tumor markers that secrete in the blood, what test is that?
That's the one you mentioned, CA99 and
okay.
CEA.
Okay.
And I'll talk about another one that we're trying to develop for the same thing. And the circulating tumor DNA is sort of like that too. So circulating tumor DNA is mutated DNA from the tumor cells that gets into the blood probably most of the time when some of the tumor cells are dying. That's how we think it gets there. And so we can detect something on the order of 1,000 tumor cells that way with a very large blood draw, and if you're lucky, but not in everybody and not all the time. And it's very expensive and it takes a while. But we're getting there with it because it's really specifically measuring that. And so like she just showed on the last slide, one of her last slides, that when you have a lot of that in your blood, it means there's a lot of tumor cells that are dying or that are around, because tumor cells die at some rate anyway. Mm-hmm. And so if there's a lot of that in your blood, it tends to be a bad prognostic factor, and we think that it may be useful. It's pretty clear that it can be useful if we can find a way to use it practically to try to understand whether therapies are working earlier than we can tell it with a CT scan or a PET scan.
Okay.
But it's still for research purposes only. It's important. We're not there yet, although we will hopefully be soon, to the point where some of these biomarkers like ctDNA or like the transposon protein that I work on can be part of routine care. They're just not quite
they're
Well, they are actually
they're in trials.
Medicare approved for immunotherapy responses, the ctDNA.
that's-
So it is. They are becoming part of standard of care. We just
but only if you get immunotherapy.
Yeah, alone. Yeah.
Right, but it would be nice if it was helpful for everybody and we could run them for everybody and we could run them a whole bunch of times and we could make decisions quicker with them. We're not quite there yet.
Okay, so for my question is in a clinical setting for proteins like HER2, right? Would you give out Herceptin or something like that if it's not show up in the tissue testing, but it is expressed or shown up in the circulating DNA?
Great question.
Yeah.
Yeah, I guess.
That's a really good question. I think, we always like to see it in the tissue. If we did not pick it up in the tissue and we saw it in the blood, I don't think we don't have the data in granularity to say what level is, what level can I see that would suggest that adding Herceptin or trastuzumab would be beneficial. I think, but I think in my practice, since we really do want to try to increase the response rates and get the best outcome for patients who are, this can be sometimes quite an aggressive disease. I think if I saw a high signal in the blood and it was not picked up in the tissue, I might still consider using trastuzumab in addition to chemotherapy. And the reason being is that it may be reflecting that tumor heterogeneity, right? Maybe that one biopsy that you took and you tested HER2 there, it didn't have a lot of expression or it didn't meet the criteria or it didn't. But maybe this tumor somewhere else in the lung or some other spots are expressing HER2, and that's what you're picking up in the blood. So you're picking up this, different clones and different sites that might benefit from that targeted therapy. So by that rationale, I think I would add targeted therapy, and that's why getting this blood test is very helpful, especially if you don't have tissue or doing it in conjunction, because it'll, I think, open the door for more patients having options for some of these targeted therapies that you might miss with just a biopsy.
Yeah, I agree. I think if you came back with that result, so HER2 we score 0, 1, 2, 3, and the ultra high levels are done with the immunostain, just the protein level. But when the level is intermediate, the reflex second testing is what's called a FISH, which means that you use special probes to count the number of DNA molecules per cell. Because the mechanism of HER2 is amplification, right? It's that there's too many copies. It's not a mutation like other things. So it will be challenging. Well, I agree that if you knew in the blood that it was up and could act on it, that would be terrific. But you would want to make sure that it really is up. And because it's an amplification, it's not going to be a thing that's a really obvious signature straight up. So in that case, I would probably recommend, if you could do it, repeat biopsy. But I also think it's a very reasonable idea that you might just treat it empirically, especially if the additional treatment has little side effect. Does that make sense? But repeat sampling, like, people don't often take another biopsy sometimes when it's actually maybe not that hard, given the stakes in play.
I would have a hard time ignoring HER2 amplification on liquid ctDNA, knowing the fact that trastuzumab is safe and knowing that what a difference it can make in patients' outcomes. Yeah. So I totally agree. I think we know it's notoriously heterogeneous disease. So you can biopsy 3 sites and you'll get different markers. You could. And so a ctDNA, almost the blood test, kind of gives you like a bird view of multiple different sites at the same time, potentially. But I totally agree. I would have a hard time ignoring it.
Yeah, definitely would not ignore it.
Yeah.
Hi, I'm Lisa. Thank you all for being here, of course. And also, I wanted to know if you ever heard of a blood test, CA74-2, and can that be used in conjunction to give you a better clinical with the 19 and the CA?
I know that one.
Yeah. I found it on ChatGPT, so I really don't know.
742? I don't know that one.
Well, that's the numbers? See, I think that ChatGPT is hallucinating. Is that what it's called?
CA 72.4. but I did pray for the plus, so it might be possible. And the other question I had is if you had a ctDNA, I did when I was diagnosed with stage 4, I have diffuse gastric cancer with METs and a biliary stricture, and I have CDH1 with a double hit. If you have all of that, when I initially did my ctDNA, it came back with nothing, which was expected that was very possible. I recently did another one, and it came back with a lot of new mutations, tumor mutation burden that went from 2 to 7, and just a lot of things were on it. Is it reasonable to expect, and I know this is going to be a hard question, but is it reasonable to expect my oncologist to take that a little further than, yes, it confirms that you have CDH1? Like, what should I have expected my oncologist to do? I thought that she would go to genetics or whoever the appropriate person is and say, is there anything targetable here? There's a lot of new stuff, but I don't know its reliability. But I do know I had KRAS on my initial biopsies, and it's there now. And she just keeps telling me that there's nothing, and I know KRAS is targetable. And
Well,
this
we
is
are
at
trying
Memorial-
to make KRAS targetable. So it's been untargetable for many years. There's many drugs in development. There's nothing really approved for KRAS mutations outside of KRAS G12C mutation, a very rare alteration, which is really unlikely to find. And so she probably, I mean, the reality is there's probably nothing that's approved for the mutations that are found, but that doesn't mean there are no drugs in development.
Okay, like SHP2 inhibitors?
That's some of them, but also there's KRAS inhibitors, pan-KRAS, specific KRAS inhibitors.
There's TOR inhibitors that's downstream of KRAS. There's ERK inhibitors, and there's 100 drugs in development that hit different mutations. And
So should I expect my oncologist to be taking this one step further in any direction?
it depends what your specific mutations are, right?
Right, of
And
course.
so I have a slide on this actually, so we
Oh.
can come back to this later.
Great.
But I think the question is always, are there trials that you become eligible for based on mutation, and can having that result help funnel you towards such a trial? I think these people, both these folks are better to answer that than I am, but that's our hope, is that we can have these molecular markers earlier inform a plan B and a plan C. Because one of the problems we have in gastric cancer right now is there's not even really a plan B.
Yeah.
Right? And so when there's not even plan B, even if you figure out earlier that plan A isn't working, it's not always clear. And it depends a lot on the specifics, like when should you switch versus when do you just stop because you're hurting somebody. These are all really wide open questions. And the exciting part is that there's a huge pipeline of new options that are potential. Mm-hmm. But the difficult part is that the clinical data to go from this might work to we know in you that this has a high chance of work, there's a huge gap there. Yeah. And so that's kind of that's the place we are right now, I think. Does that sound right?
Yeah, I think, these tests are so informative, but they can also give you a lot of information that, you're not sure what to do with, right? So sometimes you do these liquid biopsies, ctDNA, and again, there are different types of ctDNA testing as well. It sounds like maybe this was one that characterized the genes that could be picked up, and sometimes you get a list of 2, sometimes you get 10 different mutations, and I think the thing to sit and ask your oncologist is any of this meaningful? Does it give us any more information? And I think sometimes there are some mutations that we are aware of that might, this suggests maybe this is why your treatment's not working. This mutation has been linked to resistance. We can tell you that. Other times, we can look at the total number of cell-free DNA from tumor, and if it's going down, we can give us signals that maybe some treatment was working. If it's going up, maybe not. We have to always put it in context with everything else that's going on, though.
I understand that it's more than just clinicals or that.
Yeah, and then I think it's still very helpful though, because you have you have a KRAS mutation, and you ask, are there any trials that you know of in the area that I might be eligible based on this information, and so. I think that's how I would try to approach it, and at least what I try to do in the clinic.
But that will take up all of the 3 minutes that she gives me for all my questions.
CA72, I don't know that.
Hello, I've been on Herceptin after Herceptin and Folfox. I've been on Herceptin, I guess it's been 7 years now. And it's the first I've even thought about the cells changing. So is that risk quantifiable yet? Do we have enough data to, because now I'm thinking, hey, do I slow down or stop Herceptin because those cells may change, for the HER2, so that's my question.
We have no idea.
Okay.
7 years on Herceptin, we don't even know whether you have cancer. But it's like, why do anything different if it's working, right?
And that was my thought initially.
Yeah.
Yeah, that was my, thought initially, but after hearing it could change, that just popped in my head, so.
I have a slide on heterogeneity and resistance, and so that's the risk, is that, the cancer had, when you were diagnosed, something like 100 billion cells or some trillions of cells, depending on exactly how big it was. And it got there by having overexpressed HER2, and that's part of the reason you were able to clear it. And so the risk is that program changes, and that one of those clones from that many billions of cells learns to grow without HER2. But the risk of that is going to be entirely patient specific, and the fact that you're 7 years out and you're surviving with it, absent a compelling reason to change course, it seemed like an awful idea. I think one of the nice thing is that as was mentioned, that it's not a very toxic therapy, and you've made it out 7 years. But there are other therapies that are toxic that we would like to know, okay, can this patient stop? Or can we wean you off? And this is one of the places where we're hoping that minimal residual disease markers could be helpful. But again, you have to do the trials, and then you have to have people who are made it some number of years out, who are then willing to consider, or who want to consider, maybe I should try less or more, and then figure out if I do better or not. So we're not there yet, but.
Yeah, I think while we may not have all the data to tell us to do this, I would be curious, if you did tumor-specific ctDNA testing as another glorified tumor marker to see if is there something still out there, is there not? Now, we understand even if ctDNA is not detected, it doesn't necessarily mean there's nothing out there. It might just be indolent, less than what we can detect, but if it's positive, it means something is there. And can we use this test one day, to help us understand who can come off these therapies, who have durable responses? Are we able to de-escalate and take a treatment break or stop it? I think those are some of the ways we'd like to use this test in the future. And while we are absolutely not there yet, even after surgery, can we de-escalate the surveillance, right? I think none of us would do that right now if your test was negative, but. How can we use that test to escalate or de-escalate?
It would be very interesting. ctDNA in you would almost certainly be negative, right? So at Mass General anyway, as of about a year ago, the last time we had this conversation or looked at the data, at the time of clinical presentation with stage 3 gastroesophageal cancer, the commercial ctDNA tests were only present about 40% of the time. Stage 4, it's higher. But so if that's where you are at the time of presentation with the burden of disease at stage 3, then for people like you who hopefully only have 0 or a very small number of residual cancer cells hanging out quietly someplace and hopefully suppressed, and hopefully they don't kill you and you die of something else. That would be amazing, right? And a long time from now on a beach somewhere, right? But so, I think the question of whether that test would be helpful, other than as if it comes back positive, then it's interesting because maybe you learned something, but it may not be covered. It might be quite expensive, and it's an experiment, and it's sort of a one-off experiment in your case. That was fun.
Just one quick question. I'm coming. Sorry. Just because we're live streaming. This kind of goes back to, it was at Dr. Wu, the first presentation. She had talked about removing all, I guess it was the lymph nodes that drain the stomach cancer. Mm-hmm. So if you hadn't had that done at the time of surgery because you didn't know you had that type of stomach cancer, is it worthwhile to go have another surgery to have those removed after the fact?
Yeah, I think, for the standard surgery is for stomach cancer is gastrectomy and a D2, which means the extent of lymph node dissection. So I think if, it depends on the stage of the cancer you find. Sometimes we do, patients get surgery for some other reason, and then you look at the path and, there's a cancer there. I think absolutely it depends on what the stage is, and if it's someone who otherwise would have or should have gotten more of a lymph node removal, I think it does beg the question to ask the surgeon again, do you go back? Now, it's very difficult, I think, to go back for a surgery so soon after a big operation. So that, there might be some strategies like, do you give some chemotherapy first before and go, complete the surgery, or do a bigger operation down the line? But, if you get a substandard or subcomplete surgery, it certainly may impact the ability or the successes of the surgery. So I would absolutely discuss that with the surgeon.
Yeah, the data from Japan are very clear that an extensive lymph node dissection and really getting all the draining nodes makes a difference when the cancer is advanced. But I don't know the data well enough, and it would depend a lot on the specifics of the stage of the tumor and what surgery was done and how many nodes were resected as to whether an additional surgery, which is a big deal, would make more sense than some other therapy at that point, because the survival benefit from getting those few extra nodes is not gigantic. It's real, and it's real enough to make it worth doing when you're in there, but I think the question to go back is a hard one. It's a really hard question that would really depend on the circumstances and how incomplete people thought the dissection was, and whether it really was thought to be an incomplete dissection, or whether the nodes were just really small, for example, and there weren't that many called, or something like that. And there could be some subtle mitigating factors that would be a longer conversation.
And you would say every time somebody gets something removed that is cancerous, like stomach cancerous, you should have that tested, right? To see whether there are new mutations, to see how those cells differ from the ones that were biopsied initially.
You mean the workup of a resection versus of an initial biopsy?
Well, okay, so you had a stomach tumor removed initially, and then later on you have metastasis, and you have that removed. There could be some difference, right, between those two cell cultures. And so they should always be thoroughly tested. Is that right?
I do that in my practice.
Yeah, we do that too. And we actually are often, although it's not necessarily standard of care, a lot of the oncologists and a lot of pathologists are doing it anyway, is that especially if something was borderline, but we will repeat the standard tissue biomarkers on the resection from the biopsy, because if you think about it, if the tumor is the size of that screen, the biopsy is like the C in the top corner. And so depending on what's happened in the intervening time, you might have a lot of tumor to look at, or if these guys have done their job and then you send it to me, there's like nothing. And what you have left is actually fewer tumor cells than were on the biopsy to start. It just depends on the luck of the situation. But if there's a complete pathologic response, which we're seeing more and more of with better and better protocols, then on the actual biopsy, you can run all the markers you want, but you're throwing them out into the wind because there's nothing there to test. So that's the that's the trade-off.
If you're going to start a new therapy, and if you have tissue that was just biopsy, then I would like to know what is the latest thing that's growing. How about that? So if you had like all your treatment, then you had resection, nothing else needs to be done now, that's probably less crucial. But if I'm going to decide how to treat something because something is growing now, I would like to know. Because even PD-L1, or not even, PD-L1 is notorious for not being the same, and also notorious which pathologist looks at it. It's a tough biomarker.
Not even which pathologist, but which antibody was used. So actually, not only that, but for some of the trials, you actually have to run a particular protocol for the antibody, even though the antibodies are all to the same thing. It's validated in one setting, one clone, one machine, run a certain way with a threshold.
Which is actually why FDA approved the recent drug. They don't care which antibody.
Correct.
They just gave PD-L1 1%
Correct.
or higher. So, but my point, I think we all agree on the fact that the latest information gives you the most updated information on the tumor.
Yeah.
If you can.
And you had mentioned EB1 at one point. It may be run or may not be run. I wasn't sure what
Epstein-Barr
that
virus.
is. Oh, Epstein-Barr. Thank you.
EBV, I'm sorry.
Oh, EBV. Okay. All right. Great. Thanks. I just wanted to clarify what that was. Thank you.
Well, thank you so much, everybody. I think we are at our break. We'll have a break for 30 minutes and then reconvene here and for another session. Thanks, everybody, for really amazing questions,
Yeah,
which means everybody was listening.
Now we also have Dr. Woog and Dr.
Okay. We might want to just then give them lives over in matches then, or if that's a...
They are. Okay. It's 3:30 p.m. presentation. This goes through the whole thing. What's not in there is the video.
Good afternoon. Welcome back. Hopefully everybody got some coffee and ready for even a better session now. Our first speaker is Dr. John Woog. Dr. Woog is an ophthalmologist, educator, researcher, and patient advocate. A valedictorian graduate of Jefferson Medical College, he trained in Johns Hopkins Hospital, Harvard Medical School, and the best of them all, University of Wisconsin Medicine. As a Heed Fellow. Now everybody's awake. He has held academic and clinical roles at Tufts, New England Medical Center, Harvard, and the Mayo Clinic Alex School of Medicine, earning multiple teaching awards. An accomplished researcher, Dr. Woog has authored over 65 articles, 30 book chapters, and 3 books while serving as a peer reviewer and editorial board member. His leadership includes roles at Harvard, Tufts, and Mayo Clinic with recognitions from the American Academy of Ophthalmology and the American Society of Ophthalmic Plastic and Reconstructive Surgery. Following his own stage 4 cancer diagnosis and successful experimental treatment, he became a dedicated patient advocate, co-authoring Facing Cancer with Hope and speaking in national conferences. As a certificate and subject matter expert for the Patient Advocate Certification Board, he continues to support patients, advance research, and promote access to innovative therapies. Please welcome Dr. Woog.
No, thank you. Well, thank you, Dr. Boa, for that very generous introduction. And I have to say, of all my experiences, my time in Madison was pivotal, not only academically, but because that's there where I met my now very patient wife, Mariana. So, but thank you again for that introduction. And I'm very grateful, certainly to Aki and Team Hope for arranging this superb meeting today and for the invitation to speak. We've heard a tremendous amount and far more elegant presentations in terms of definitions and discussion of biomarkers from Dr. Ubohan, Dr. Mukherjee. So the only difference is after my talk, there will be a test, so please pay attention. No, there won't be a test. But after just a very brief summary discussion, we'll present a vignette which perhaps will help put biomarkers into perspective in terms of both the opportunities and challenges and hopefully strategies for improvements in clinical outcomes. These are my disclosures. And certainly it's very important to note that cancer is a formidable disorder. Nothing that I might share today regarding my experience is meant to substitute for the advice and guidance that everyone should get from their own personal care team. Well, we've heard a lot about biomarkers. We won't belabor the definition. Basically, these are any biological molecules, and there are many, many different types that may be found in individuals with cancer. We've heard a number of comments about the various roles of biomarkers, which can include assistance in therapy selection, and in the case of ctDNA, as we just heard, monitoring the response to treatment and or detection of recurrence. Biologically, there are multiple classes of biomarkers, which again we've heard about, including DNA, the genetic material within our cells, RNA, which is prepared from DNA during the process called transcription, proteins, which are basically the biological machines that enable life functions, and a number of other metabolic molecules associated with cancer cells, as well as microorganisms, and even environmental exposures may fall into this category of biomarkers or multi-omics. This is a partial list, and again, we've heard these beautifully discussed by our earlier colleagues of some of the biomarkers associated with gastric cancer. The ones designated in green have current FDA-approved therapies that are relevant. The ones in yellow are under investigation. I'm particularly enthusiastic about hearing from our last speaker today, Dr. Taylor, about a very exciting new class of protein-based biomarkers, the line 1 ORF proteins. We'll shift now to discussion really of a more personal experience, which I hope may illustrate some of the potentials as well as challenges associated with biomarker-directed therapy. My personal saga, in fact, began a long time ago. This was before much of what we have heard about today was available. No next-generation sequencing, no multiomics, certainly no circulating ctDNA, no immune checkpoint inhibitors, no antibody-drug conjugates, bispecific antibodies, not even any neoadjuvant or pre-op chemotherapy, which is now standard of care. Targeted therapy itself was just in its infancy at that time. This was only back in 2007, so it's remarkable to see really how far we've come in that time. But like so many of us in the audience, I thought I was in good health. I was active, professionally, ran, etc. When I was diagnosed with stage 3B, poorly differentiated signet ring cell cancer, I underwent complete gastrectomy. I had a D2 resection and, as we heard earlier, received discouraging information in that 36 of the 50 lymph nodes that were sampled were actually positive. Based on the information that was available to us then, this again prognostically was discouraging. We sought email consultations with folks both here in the U.S. And abroad, particularly in East Asia, where there's a very important base of experience. And in discussion with my oncologist, we settled on a regimen of oxaliplatin and S1 as adjuvant chemo. S1, for those folks who may not be familiar with it, was an oral 5-FU prodrug similar to capecitabine. At this point, our goal of treatment was cure. I did pretty well on this regimen over the course of the summer, was recovering, was really looking forward to getting back to work in September when I had a CT scan to evaluate some digestive issues at the time. My GI tract actually turned out to be fine, but I was shocked when the scan was found to reveal liver met, a solitary liver metastasis seen outlined here at the red box. Well, this was discouraging news because, as we heard earlier from Dr. Wu, at least the information at that time was that metastatic stage 4 cancer was associated with very poor 5-year survival, in fact, median survival of only 7 to 15 months. In an attempt to improve on those odds, we decided to embark on what was then a relatively new approach, namely targeted therapy. Again, gene sequencing was not available at that time. My tumor showed an increased number of chromosome 7. Normally, we have 2 copies of each chromosome. I had more than that in my tumor cells. On chromosome 7 is located an oncogene or a protein called MET, which we heard briefly about a bit earlier. And based on this information and also based on a number of recently published papers linking this MET, pardon me, if we can go back one slide, that would be great. Linking MET to stomach cancer, we decided to embark on a clinical trial targeting this MET pathway. I ended up on one trial, this trial in Chicago, but unfortunately failed within 3 months. Over the next 14 months, we tried a number of other things, including a major surgery where part of my liver was removed. Unfortunately, nothing worked. I had major significant medical issues associated with treatment, including a collapsed lung and a serious spine infection necessitating emergency surgery. I was getting more abdominal pain, and my liver function was declining as my metastatic disease progressed, as seen here. We had, based on my functional status, my liver function, et cetera, we had basically one more shot at treatment at this point, and we were considering yet another trial. This would have been the third trial that I would embark on targeting this MET pathway, but wanted to make sure that this was in fact the best option to pursue at this time. It was at that point that we came across a recent article on c-MET by a research scientist who specialized in this pathway. I emailed the scientist who very kindly studied tissue from my tumor using specialized proteomics techniques in his lab. For Marty, these are phosphoproteomic techniques, and perhaps you can explain that better than I can later, Marty. But at any rate, the goal of this examination was to see whether, in fact, it made sense to pursue another MET-directed trial. These studies revealed, in fact, that only less than 3% of the cells from my tumor revealed evidence of MET pathway activation. The scientists kindly looked at other cancer-related pathways, however, including one called HER2, and this was highly positive for HER2 phosphorylation or activation. In the words of the, in the words of the scientists, the slides stained for HER2 were full of signal from every cell in every corner of the tumor. So it seemed like HER2, not MET, was actually the key factor here. At the time, we knew that HER2 was a protein that led from, as we've heard so nicely described earlier, from the cell surface down to a series of pathways that ultimately reach the cell nucleus and drive a cell proliferation and improve cell survival. HER2, we knew, was overexpressed in about 20% of individuals with breast cancer and was associated with more aggressive biologic behavior of these tumors. HER2 was actually one of the earliest biomarkers identified, and the story of its discovery and the subsequent development of HER2-directed therapy, I think, is relevant really to biomarker-directed therapy in general. The gene and protein were discovered in the early 80s, but it wasn't until 1998, 15 years later, that trastuzumab was approved by the FDA for treatment of breast cancer. I'm sorry we don't have the time to relate this story in great detail, but I'd highly recommend the book by Robert Bazell if you're interested in learning more. In brief, I guess I would say it's an absolutely riveting tale that combined brilliant basic science, the absolutely dogged persistence of clinical oncologists, and steadfast patient advocacy and philanthropic efforts with really, I'd say, healthy doses of serendipity thrown in there. It's sobering when you read the story to realize how close we came to not having trastuzumab, in fact. At any rate, the scientist oncologist team behind the development of, or recognition of HER2 and development of trastuzumab were recently awarded the Lasker Prize, which is often a precursor to the Nobel Prize in medicine. Well, we know biologically, we've heard already that trastuzumab is a protein. Specifically, it's a monoclonal antibody. And our next speaker, Michelle, Dr. Bilderschieß, mentioned we should mention that whenever you see, MAB at the end, that usually means it's a monoclonal antibody, just as a cue to medical terminology. It blocks the Herceptin receptor at the level of the cell membrane, preventing activation of these downstream pathways. It may also, as we've heard earlier, work via immune-mediated mechanism. It may bind to and activate in specific the natural killer cells that we heard about earlier, which can then allow or potentiate cancer cell destruction. Well, returning to, pardon me, my story, back in 2008, trastuzumab was approved only for breast cancer. A study looking at trastuzumab in HER2 positive stomach cancer was just being organized at the time. This is the TOGA study that Dr. Mukherjee had mentioned earlier. We were able to find at that time, though, a case report of a patient with HER2 positive stomach cancer who had a good response to trastuzumab. And based on that study and on the findings of these research lab analyses of my tumor, my oncologist was gracious enough to write a single patient, so-called expanded access protocol for what was then experimental treatment of HER2 positive breast cancer. The protocol was approved by our IRB and by the FDA. And I started therapy. Shortly after starting, I developed a massive blood clot in my arm requiring anticoagulation. I continued treatment, and at the 1 month point, as is often the case in clinical trials, we got a CT scan to see where things stood. And to this day, now some 17 years later, I still remember, as I think many of us as patients have had this feeling, you're on the CT scan table and you're hearing the high-pitched hum of that CT scanner and wondering anxiously what the scan would ultimately show about the success of what was at that point likely my last shot at therapy. Fortunately, the scan showed improvement. I ended up staying on trastuzumab, combined in fact with lapatinib, a small molecule tyrosine kinase inhibitor, which acts at a more distal or internal part of the same pathway for the next 9 years, in fact. I've been very fortunate that my recent scans have shown no evidence of metastasis. Well, thank you. I'm very, very, very grateful. We've learned a lot since then, certainly about HER2 and gastric cancer since 2008. We've learned that, like breast cancer, about 20% or so of gastric cancers are HER2 positive. The nature of HER2 positivity is different, and all of our earlier speakers and Marty in the panel discussion commented on this. Many stomach cancers show only patchy areas of HER2 positivity next to areas of tumor that are HER2 negative. The technical term for this patchiness, which we've heard again from our earlier speakers, which has implications, in fact, for how well a tumor may respond to anti-HER2 therapy, is heterogeneity. Speaking of therapy, we mentioned the TOGA study. The results were published in 2010, showing a statistically significant improvement in survival in patients, again, with advanced recurrent metastatic HER2-positive stomach cancer combined with chemo, and this led to FDA approval of trastuzumab for this additional indication. One might ask, well, so we're seeing on median a 2.4-month improvement. Now, obviously, some folks do a lot better, but some may not do as well. And one might ask almost, why didn't we see more dramatic results if we identified this biomarker? And one important possible reason may in fact be the tumor heterogeneity process that we mentioned earlier. And as Dr. Taylor alluded to earlier, with time, due to the intrinsic inherent genomic instability of cancer cells, we may see more and more mutations develop, resulting in some clones, at least, of cells which may be resistant to various therapeutic answers. It's also possible, and I'll certainly appreciate the input from the more knowledgeable folks on the panel, that there may intrinsically be some cells that from the very beginning are more resistant, such as cancer stem cells. Specific mechanisms of resistance can include an actual decrease in the number of receptors on the cell surface, as well as the ability of cancer cells to develop the energy that they need to survive and grow via alternate pathways. One other mechanism which I personally am particularly intrigued by is the activation of these so-called downstream pathways, or what are called cross-talking pathways that are parallel to the HER2 pathway, that essentially allow the cancer cell to bypass the effects of trastuzumab. The principle of cross-talking, I think, is familiar to any of us who've driven on the DC Beltway, if you live in this area, or I'm sure every other metropolitan city has the same sort of highway system. Basically, if one route is blocked, so to speak, traffic is redirected down parallel interconnecting pathways. Unfortunately, cancer cells manage this rerouting process far more efficiently than human drivers do, but this may, I think, be a very pertinent mechanism, at least for some individuals. Well, given the tremendous challenge of resistance, how do we explain situations where, in fact, the response to treatment exceeds expectations? These are sometimes termed exceptional responses or exceptional responders, and one might wonder, well, what actually worked? And personally, and again, this all now is falling more in the realm of speculation than evidence, but personally, I do wonder whether early diagnosis of metastasis may have limited the opportunity for these multiple clones of resistant tumors to develop. A phenomenon certainly that has been discussed is oncogene addiction, where certain cancer cells are absolutely dependent on one gene or one pathway for their survival. And if you block that pathway, if you block that gene, that results in the death of the cancer cells. There are several possible mechanisms, and I'm not an expert on oncogene addiction. Again, we may hear more perhaps during the panel about this, but just with a very crude cartoon. I loved your cartoons, by the way. These are not as elegant. But on the top, we see an example of a homogeneous tumor where basically all the cells are dependent on this green pathway here. When treated with this anti-green therapy, maybe it's trastuzumab, the cells all die and the tumor dies. On the bottom, with a heterogeneous tumor, on the other hand, some of the cells, some of the clones are responsive. They're eliminated by the anti-green therapy, but that actually allows the resistant purple cells or purple clones to expand. And in fact, there's been some discussion that maybe it's better in some cases to leave a more mixed environment of cells to prevent expansion of what may be potentially a more aggressive clonal population. Another factor contributing to exceptional responses, and again, this was very well discussed earlier, are combination therapies, which may inhibit development of resistance. Any of us who've had a significant bacterial infection know that often we're treated with a combination of antibiotics to prevent resistance to a single organism. And this is certainly one of the rationales for combining cytotoxic chemotherapy such as oxaliplatin or 5-FU. Another type of combination may be the dual inhibition of the HER2 pathway, both at the surface and more internally. In addition, it's possible, and again, this is all in the realm of speculation now, but I had been on 2 clinical trials targeting this MET pathway just prior to starting trastuzumab, in fact. We'll go back here. It's now known that this MET pathway crosstalks or interacts with the HER2 pathway. So it's possible that even though I, quote, failed the MET-directed trials, that in fact these ended up being helpful by blocking this crosstalking mechanism. Yet other possible factors in terms of my personal outcome included the use of supplements used in Ayurvedic and East Asian medicine that may have anti-proliferative or immune-stimulating properties. Again, this was before the current immune checkpoint inhibitors were available. Overall, and I can't reiterate Dr. Taylor's comment earlier enough, I was very, very fortunate to have had tremendous support in identifying and accessing effective treatments for my cancer. Well, we'll just move along, and we've heard much of this already. A number of additional therapies targeting HER2 have been developed over recent years. We talked about these small molecule tyrosine kinase inhibitors. Although the trial results were discouraging, and this information stands in distinction to breast cancer, where the combination of trastuzumab and the tyrosine kinase small molecule inhibitors has been helpful. From what I've read, and again, I'd appreciate more informed opinions about this during the panel, there may possibly still be a role, particularly in patients with highly HER2 positive tumors. Particularly exciting, and again, we won't belabor the structure of the antibody drug conjugates. I believe the last I read, there were actually over 200 in development, not for gastric cancer, but for cancer in general. The goal, again, is to target delivery of chemo with greater effectiveness, possibly lower toxicity. And as Dr. Mukherjee mentioned earlier, the bystander effect, I think, is really a very interesting conceptual advantage of these drugs. If you can visualize having a HER2 negative population next to a HER2 positive population, and this payload is released, hopefully that will help eliminate some of the HER2 negative cells as well. We heard again about one of the prototypes here, trastuzumab deruxtecan in HER2, and again, this bystander effect, I think, is particularly exciting. Yet another really promising innovation are bispecific antibodies, which, as we heard earlier, actually attach to two separate parts of that HER2 receptor, resulting in increased blockade of the receptor. Actually, the receptors may be internalized into the cancer cell and are not then available for activation. Also, these agents may be associated with actually three separate mechanisms for immune system potentiation or destruction of the cancer cells. Zani, to use its colloquially shortened name, was, as we heard, approved in November for HER2 positive biliary tract cancer. Its phase 2 study results for gastric cancer were very encouraging, and currently there's a phase 3 study ongoing. Time, unfortunately, will preclude us from discussing all of these very exciting developments on slide left here, many of which target or attempt to utilize the immune system to, again, potentiate cell destruction. I would really be very interested to hear during the panel about what folks think about the personalized cancer vaccines and how they may interface with our current cytotoxic and targeted therapy or immuno-oncology agents, et cetera. Well, what lessons may we have learned from the HER2 story? First, at least from my personal perspective, genomics certainly may be helpful, but multi-omics may be even more useful, perhaps in selecting therapy, at least in some patients. Again, this is speculative, but early detection of cancer and of cancer recurrence or metastasis may reduce possibly the emergence of resistant clones, and perhaps ctDNA testing, as we're looking forward to hearing about from our next speaker, Dr. Beidel. May play a very helpful role in this regard. Combination therapy, as we discussed, which can include not only cytotoxic therapy, but targeted agents, immune-based agents, as well as dual blockade of targeted pathways. And I think an area which I'm hoping will receive increasing research emphasis is elucidation or identification of these cross-talking pathways, and then development of strategies to block those pathways and hopefully reduce the incidence of resistance. We discussed integrative medicine, as we all know, and we had wonderful presentations earlier in the summit about the importance of gentle exercise and nutrition and maintaining our performance status, which will hopefully allow us as patients, as we follow this exciting research, to remain eligible to participate in the relevant clinical trials that may extend beyond NCCN guidelines and even, when appropriate, participate in expanded access protocols as well. In closing, as patients and caregivers facing stomach cancer, I do think there are a number of reasons we can look to the future with hope. AI, and you could have in fact, there are entire conferences dedicated to AI in oncology. It really may transform cancer care from diagnosis, hopefully early diagnosis and interception, on through clinical trial design and drug design and repurposing. Last year we heard about the ASCO TAPR program, which facilitates access of drugs approved for one indication for patients with similar genomic signatures with other anatomically located tumors. Trial GPT is a really interesting, intriguing AI-enabled platform that will hopefully help ensure that each patient is matched to the clinical trial which is most appropriate for them. And finally, if I can leave you with one maybe take-home point, because everything I've said today was pretty much covered by our other speakers earlier, but from the consumer perspective, if you can make a note of this URL, openevidence.com, it's an AI-based platform. I would consider it a supercharged combination of Google and PubMed, with a little bit of clinicaltrials.gov thrown in, which can allow you to identify among vastly expanding universe of biomedical information that knowledge which may be particularly relevant to your situation or your loved one's situation. In summary, we can all take comfort, as well as patients and caregivers, from the support that we receive from a complex ecosystem, including partners in academia, healthcare delivery, government, and biopharma, certainly, that has really enabled the development of the majority of new cancer diagnostics and therapeutics. As in the case of trastuzumab, the process of new cancer drug development can be lengthy, challenging, and expensive, with some estimates being up to $1 billion or more for development of new drugs. We'll have the opportunity tomorrow, as we travel to Capitol Hill, to emphasize to our representatives and policymakers in Congress the importance of supporting this very delicate, very important innovation ecosystem. Thank you very much.
Thank you so much, Dr. Wook. That was amazing, inspiring. I'm glad I didn't have to present after you. But that brings us... just joking. That brings us to our next speaker, Dr. Michelle Beidel-Schiess. Dr. Beidel-Schiess is the Director of Medical Affairs for Multi-Cancer Early Detection at Exact Sciences Corporation. Prior to her current position, she was the Director of Research and Education for Cleveland Clinic Center for Functional Medicine and an Assistant Professor of Medicine for Cleveland Clinic Lerner College of Medicine. While at Cleveland Clinic, she also completed a fellowship in the Center of Value-Based Research. And Dr. Beidel-Schiess was previously the Director of Education and Clinical Affairs for Cleveland Health Lab Incorporated, a Quest diagnostic company. So please welcome. I was joking about the prior speaker, of course.
Oh, no, you're fine. Thanks. I'll just step here.
It's getting a little tight here.
I appreciate that. Thank you. Yes, it is a very hard act to follow. Fantastic, fantastic presentation. Also a very difficult name as well. Just as a reminder, my name is Michelle Beidel-Schiess. I'm the Director of Medical Affairs for Multi-Cancer Early Detection at Exact Sciences. I am truly humbled to be here to hear all of the stories sitting in this room from everyone. Everyone is quite brave, and I feel blessed personally to not have to have the worries that you guys have. It's a very hard route. That doesn't mean it doesn't affect other parts of my family, and I'll get to that in a moment, but you guys truly are brave. I was asked to give a presentation today about some of the technologies that we have from our company and talk about diagnostics for tomorrow. I'd like to talk a little bit about early detection technologies. You heard a little bit about molecular residual disease and MRD testing. And then I want to talk about genomics-directed therapy. So these are my disclosures. You don't have to read them all. I guess I should also say that I am not a physician. I am not an MD. I'm a PhD. My kids constantly remind me of that. They call me a fake doctor, and they will be paying for their own college education. So if anyone knows of any scholarships, please let me know, or I'll give you their email addresses. But I did learn a little bit while I was in school, so I'll give you that. As I was sitting initially in the back of the room, we were having some conversations, and I was listening to everyone's stories. And I was starting to think about my career and how I got to where I am. And, I started in graduate school doing cardiovascular research. It was near and dear to my heart, just like stomach cancer is near and dear to yours. And I was doing that because I have heart disease in my family. My father had multiple heart attacks. My mother had a stroke. My cousin, who was 32, died of a massive heart attack. And I was like, I'm going to learn about cardiovascular medicine. And that's what I did. Then I transitioned into industry in a cardiovascular diagnostics company because I thought to myself, it was all focused on prevention. And I thought to myself, well, I'm going to identify biomarker technologies and help people learn about this technology so they can be empowered to do something about their health. And then I transitioned to, I should say, while I was at Cleveland Clinic, my father ended up having an aortic aneurysm. So it helps to be at the #1 cardiovascular center and know people, and they actually saved his life. And then I transitioned to Exact Sciences, who obviously is focused around oncology, and I got a little nervous because I didn't know at the time anyone with cancer. And then my father ended up with myelodysplastic syndrome, which is a blood cancer. So I feel like my entire career has been centered around what has impacted me and my family. And I've really been that steward of trying to connect the dots as it relates to education. And sometimes when you get these messages through MyChart or whatever your app is for being a patient, they say, do you need a translator? And they typically want to know if you need someone to speak Spanish or whichever language that you speak. And to be honest, we really need translators in terms of education and the knowledge that is needed to make decisions for your care. And I've been very fortunate to be able to be that for my family along my career path. I came to Exact Sciences mainly for this mission here, which is because it's focused around prevention and early detection. Their aim is to eradicate cancer and the suffering it causes through the development of technology diagnostics to prevent cancer, detect it earlier, and guide treatment. So rather than having a slide that overviews everything I'm going to talk about, this is sort of the visual depiction of the conversation we're going to have. And so on the y-axis, let me see, there you go. This is tumor burden, and down below here on this sort of x-axis, you'll see all the different technologies that Exact Sciences has. As you go across, you can see that this goes up and down. This is meant to represent circulating tumor DNA, which we've heard a lot about as well, and how our different technologies map to that. So as part of my presentation, we're going to start first talking about screening and surveillance, where we're asking the question, might I have cancer? And we're going to talk about two new technologies, Cologuard Plus and CancerGuard EX, both of which are I should say, one of which, Cologuard Plus, is not currently available yet, but CancerGuard EX is. Then we're going to talk about molecular residual disease and recurrence monitoring, where we're asking the question, is my cancer gone or has my cancer returned? And we're going to talk a little bit about OncoDetect. And then last, we'll just touch on therapy selection, where we're asking the question, which therapy will best treat my late-stage cancer? And we'll talk a little bit about OncoExtra. So last year in 2024, Exact Sciences actually celebrated 10 years of its flagship test, Cologuard. We tested over 16 million people with this particular technology. This is what's called a multi-target stool DNA test, and it's indicated for individuals who are at average risk for colorectal cancer. So when we, if I were to go back, oops, sorry about that. Back, forward. It's like a dance. If I were to look here at Cologuard Plus and look at the circulating tumor DNA, which is indicative of tumor burden, you can see that this is a screening population. So those levels, as you heard with other speakers, should be very low. But if we're detecting it specifically in the stool, then it may be indicative of higher risk for colorectal cancer. And so that's what this technology does. This technology leverages, as I mentioned, circulating tumor DNA, but it looks specifically at methylation as well as another marker of hemoglobin. And I'll talk to you a little bit about that in the next slide about why that matters. Or I'm sorry, in the subsequent slides, I should say. This slide is just meant to depict the performance of our particular test. We know that colorectal cancer, as with many cancers, is a progressive condition where you have early stages as well as late stages. When we look at overall sensitivity across all of the stages for colorectal cancer, Cologuard Plus has a 95% sensitivity overall with a very high specificity, very low likelihood of having a false positive result with a 94% specificity. A lot of people want to know, well, how does your test perform as it relates to other tests, which we commonly know about, one being the FIT test, fecal immunochemical test, and that is depicted in light blue. What you can see in the top part right here, again, this is colorectal cancer stages 1 through 4. Again, the Cologuard test has pretty good sensitivity. It's much stronger than the FIT test. And then when we look at earlier stage cancers, again, that's where we really have the best opportunity for curative intent in individuals. We can see that the Cologuard Plus test does significantly better than the FIT test. And then when we look at, and this is really the distinction with our technologies, advanced precancers, which are really hard to detect, we have a much higher sensitivity than the FIT test. So the Cologuard Plus test was more effective overall than the FIT technology at detecting CRC. And I should say, does everyone know what FIT is? I didn't even describe it. Okay, so FIT, you basically take the stool and look at if there's blood in it. Okay, so this is more effective than just seeing if there's blood there, because there could be a number of different reasons as to why the stool might have blood in it. So the Cologuard test is actually indicated for screening in average risk individuals, again, 45 years or older, as part of USPSTF guidelines. There are other cancers that are also indicated for screening, including colorectal cancer, which are for lung, which is for high-risk individuals, breast, and cervical cancers. So there's only 4 tests that have guideline screening recommendations. And these, I shouldn't say tests, screening programs. These 4 screening programs have done a fantastic job in reducing long-term mortality. Mortality is declining slowly, but they only address 1/3 of incident cancers and cancer deaths. So there are 2/3 of incident cancers and cancer deaths related to cancers that do not have screening programs. Okay, so this is really the basis of our CancerGuard EX technology. So everyone says, Michelle, why don't you just develop single cancer screens for all these different cancers? That's the solution. Then I can, screen for stomach cancer, and I can screen for esophageal cancer. This figure actually demonstrates why that is very challenging. So if we look at the y-axis, this is the number needed to screen. So that's the number needed of patients to enroll in a study to get one cancer. Okay? Across the bottom is the prevalence of those cancers. So if we were to look at these less prevalent cancers like esophageal, stomach, liver, pancreas, you can see that you need 1,000 people to be enrolled to detect one cancer, 833 for stomach, 588 for liver, 500 for pancreatic. And that's just not feasible, number one, because you need to have a significantly large study full of patients to enroll. Number two, it's quite costly to develop these types of trials and do that. So the idea that we have was to combine the prevalence of all cancers together and develop a technology that can detect them. So if we were to put all PAN, meaning all GI cancers together, that number needed to screen drops to 83. And if we were to create a universal cancer test to detect all cancers based off of these ctDNA signals that exist, the number drops further to 33. And so this is really the basis of multi-cancer screening technology that is out there. Exact Sciences has a commercially available test called CancerGuard EX that is screening for multiple cancer types. It is a blood-based technology, and currently it's being used for individuals aged 50 to 84 years with no active cancer diagnosis in the prior 3 years. Okay? So the idea for this technology really came previously from one of the largest prospective interventional trials from our group called DETECT-A. DETECT-A looked at a multi-biomarker combination test focused around mutations in proteins. And what we found in short was that this technology was able to detect, number one, a number of different types of cancers. It, in fact, doubled the number of screen-detected cancers, and we were able to detect them early. And we now have longitudinal data to show that these individuals who were deemed to have, in fact, cancer, they were considered true positives, have very favorable outcomes. Okay? So that was really the basis of this technology. This particular technology, CancerGuard EX, is focused on different biomarkers, and I'll talk a little bit about that data. It's focused on methylation in proteins rather than mutations in proteins. Okay? So let's look at this data very briefly here. So once we completed the DETECT-A study that looked at mutations in proteins, we said, well, let's look at other different biomarker combinations that exist beyond mutations in proteins. We looked at aneuploidy. We looked at a number of different combinations of different types of biomarkers. And then what we did was we launched a study called ASCEND-2. And ASCEND-2 is a case control study. So we took patients who don't have cancer and who have cancer, and we took this technology that we developed and evaluated whether or not it was really good at detecting cancer or not, not detecting cancer. And so this is data from our ASCEND-2 study. So what we found was that if we maintain a very high specificity of 98.5, a very small likelihood of a false positive rate, and we look at all cancers, our overall sensitivity was 50.9%. When we exclude cancers like breast and prostate, because they already have screening programs that are really beneficial, we're certainly not trying to take people away from what works. That sensitivity improved to 56.8%. And when we look at the 6 most lethal cancers, including esophageal, liver, lung, ovarian, pancreatic, and stomach, that sensitivity substantially increases to 63.7%. Now, you would expect that. If these are the most lethal cancers or the most aggressive cancers, that means, based on what we've heard previously, that the circulating tumor DNA is going up because these are more aggressive cancers. So we would expect the sensitivity to go up. But this is pretty good performance. But what people really want to know is, are you able to detect these cancers in an earlier stage? And so that's what this is showing right here. So in dark blue, you can see detection for all cancers, and in light blue, what you can see is detection of cancers, but when we exclude breast and prostate. And you can see that we have a pretty strong stage 1 and stage 2 sensitivity when we look at this particular assay configuration, and that continues to increase as you go through stage 3 and stage 4. Again, circulating tumor DNA goes up as the stages go up as well. So we feel very confident about the stage 1 as well as stage 2, even stage 3 sensitivity for early cancer detection. This is just a summary of the various cancer types, sensitivity of those particular cancer types. You can see on the far right, liver, followed by cervical, pancreatic, ovarian, and stomach. Stomach, the sensitivity is about 70%. Keep in mind, as I mentioned, this is a case control study. So while we have really good sensitivity here for these cancers, when you take this technology from a case control setting and move it into a prospective study setting, these sensitivities are going to drop a little bit. That's just the nature of the studies and the way in which they work and the technology. So we're not going to expect to get that high sensitivity for those particular cancers, but it'll still be high. And what we say is, right now, they don't have the means to detect these particular cancers, so any detection is good detection. All right, now I'm going to transition on to is my cancer gone or is my cancer coming back? And we're going to talk about OncoDetect very briefly. This particular test, again, detects circulating tumor DNA. And the way this works, it uses tumor-informed test design. So what that means is that if you have a particular cancer, a solid tumor cancer, we can take a piece of that cancer, put it into paraffin wax, grab a blood sample, and essentially create a personalized test for you so that you can then give us a blood sample at some point over time, and we can see if those molecular signals are still there, which may suggest that your cancer is recurring, okay? Now keep in mind, this came up in another presentation as well, or maybe it was a question from the audience. These tumors also evolve, right, over time. So we're taking it at the time of surgery. We can't account for the fact that the tumor may evolve over time. But this test in particular is meant to complement and support therapy decision-making, and it's expected to be better than the imaging that commonly occurs. In this case, we'll talk about colorectal cancer screening, as well as biomarkers like CEA. This is meant to detect these cancers a little bit earlier. So again, with the MRD, molecular residual disease technology, this is the detection of cancer that's not detectable with a standard clinical exam or imaging. I just mentioned CEA and imaging. And so if the test is positive, the idea is that your cancer is more likely to recur versus negative, which is less likely to occur. So we recently published a paper, it must be a few weeks ago now, on this particular technology. In particular, it was for stage 2 and 3 colon cancer patients. And so this is just an overview of how this technology ultimately would benefit these patients. So on the left, you can see that the patient ended up having surgery. This particular tumor was resected, and a tumor sample as well as a blood sample was obtained. And then over the course of 2 to 8 weeks, their personalized test was developed, and then blood was drawn for MRD testing. And if it was positive, for patients with stage 2 or stage 3 cancer, you would say this patient has a likeliness to have cancer recurring. Now, if you're stage 2 and you're positive, you might want to consider more chemo, but if you're stage 3 and positive, you want to consider more intensive chemo. So it's helping to guide the intensity as it relates to chemo, and then following that, you would then monitor the response with another blood draw. If the test is negative for patients with stage 2 or stage 3, the cancer is less likely to recur. And so for stage 2 patients, you can consider avoiding chemo, which is fantastic. I wish my father had that with myelodysplastic syndrome, because he actually took himself off of chemo because his quality of life was so poor. And he said, I'd rather not live this way versus taking it. So having a test to be able to help you avoid something is quite beneficial. And then for stage 3 patients, you might consider, because they're more far along, less intense chemo, and then you're going to monitor for recurrence. This particular technology could also be beneficial for those who have completed post-operative chemotherapy. So again, on the left, you can see the same situation where they have the surgery. They might complete chemotherapy, and then there's a blood draw. And if it's positive, you might suggest that that patient did not respond to chemotherapy, and they might need more surveillance or even extend that therapy. Again, keep in mind that we can't confirm whether or not that the cancer is changing in the patient as well. But you're going to continue to monitor response. And then if that test is negative, we would suggest that the patient has in fact responded to the chemotherapy, and you can continue to survey the patients and then monitor for recurrence long term. So again, this particular technology, we just published data from this. It's called the Alpha Correct study. There is another study going on. Again, the Alpha Correct study, I believe, was in colorectal cancer patients. There's another study following that up, Beta Correct. And we plan on doing follow-up studies beyond colorectal cancer into other solid tumor cancers to demonstrate the value of this technology to survey those particular cancers. I'm going to end talking one slide with OncoExtra. OncoExtra is a test for patients with advanced metastatic, refractory, relapsed, or recurrent solid tumors. And this technology relies on patient-matched, tumor-normal, ultra-comprehensive genomic profiling. Wow, that's a lot right there. But essentially, it detects alterations in 20,000 genes. And what it allows you to do, it allows you to estimate tumor mutational load and better predict the clinical benefits of immunotherapy with fewer false positives. What it does also is it evaluates the whole exome, which is the DNA, the exome being the protein coding regions. So we heard a little bit about whole genome sequencing, where you get tons of information. Whole exome allows you to just focus on particular regions for protein coding. It also looks at whole transcriptome RNA as well to guide treatment selection and available clinical trials as well. So it does put that in the report as well. So I'm going to end with a quote that came from one of the co-inventors of Cologuard. This really typifies what it's like to be on the leading edge of medicine, as many of the presenters are. And what you guys rely on is innovation in the space. And a lot of people have a fear of innovation because it's something that's unknown. So it's wonderful that people are here to help guide you through that. But it's hard, right? And so this quote, hard is not an excuse for not trying. If we can, we must. And this really demonstrates what exact science is all about. We continue to push forward every day with these different technologies to help support you, the patients, along your cancer continuum. So thank you very much.
Thank you so much, and I would like to welcome back Dr. Marty Taylor for the last talk of the session, and we'll take questions after.
Hey, John. All right, so how do I not screw it up with this thing?
Forward, laser pointer
Okay,
back.
great.
Scoot your chairs. Is there enough room?
All right, well, it's great to be back here. It's very hard to follow Dr. Wook, or Michelle, but especially Dr. Wook. So,
I mean, yeah.
So I'm going to talk a little bit No offense. You didn't have cancer and survived. When you should have died. Like, it's amazing. Right, so I think a bunch of the question is, how do we make more people like Dr. Woog? There's only one. They don't make them like that, as they say. But how do we make other people's outcomes like his outcome? So I'm going to talk a little bit about how we get there. I'm going to talk a little bit about biomarkers and a little bit about future therapy. Impossible to be exhaustive, but I'm going to just try to give like a high level. By way of disclosure, I work with a company called Rome Therapeutics, which is trying to make new drugs, not yet for cancer, but targeting transposons, and have had really great support from Stand Up to Cancer, including with Aki, which is actually how I ended up here. So I'll go through a little bit of cancer and chemotherapy from the perspective of pathologists and tell you some things probably in a way that nobody else would say it. What do we do? What is cancer? Why does it kill people? Why can't we get rid of it? And how can we do better? I'll talk a little bit also about transposons and the dark genome, what that even means, and why we think that that is coming down the pipe as something very useful. This is actually a transposon protein. I spend a lot of my time in the lab doing really basic science and then trying to translate this into therapy and into prevention. So what do I do? This is what everybody thinks I do. I do not see dead people. I did, in fact, in training, do a couple of autopsies, like about 100 actually. But that's not what I do all day. So what we do is really an important behind-the-scenes role in cancer care. And so most of what we do is diagnostics and prognostics from either a biopsy or a resection. We also develop and run new tests and molecular tests. And the basic questions are, is it cancer? And then if it is, how bad is it? What is the stage? What is the grade? Did all of it get cut out that could be cut out? Did we get all the margins? Of course, you never really get it all, which is a separate conversation, which we'll get to in a minute. And then most importantly, from what we have in hand, what therapy are you eligible for? So these are the kind of questions that we've been asking. As I mentioned during the panel, major centers all re-review outside pathology. And unlike radiology, where everybody also re-reviews it, but it is not paid for, and everybody here who has an MD is an amateur radiologist, and there are very few amateur pathologists. And so it's actually important to get it re-reviewed because also, unlike radiology, your oncologist doesn't get to look at the slides that you had taken some other place, whereas they can almost always just pull the scan up and make their own opinion. And so the next two slides have what are called gross photos. That is both a technical and accurate term as to what's coming. Just as a heads up, if anybody doesn't like blood, please don't look. So this is a stomach. This is what we would see from a prophylactic gastrectomy. This is actually from a 24-year-old man with CDH mutation and hereditary diffuse gastric cancer. And so this is fat, the yellow stuff. This is the stomach. The antrum is smoother, and then the body fundus has this more ruffled look. And then right there is a stage T3 cancer that was actually not apparent before this, I guess I can call him a kid at 24, went in for surgery, young man. And so here's a closer look. This had not been seen on the endoscopy that was taken some number of, like about a year before he decided he was going to get his prophylactic gastrectomy. And it's a really good thing that he got his prophylactic gastrectomy here. So here's the cancer. Here it is spread out. And you can see that, you know, in all the ruffles, it's kind of hidden. But if you know what to look for, you can see it. And then, of course, you can see here that there's this ulcerated mass that's actually what a mid-stage gastric cancer looks like. So the way that we stage these is T, N, and M. You guys have seen these on path reports. Tumor, nodes, METs. Those together, along with sometimes some other factors depending on the tumor type, make up an AJCC stage. Right? So T and M is part of staging. And so the T stage is where, and the N stage are usually where the pathologist comes in. By the time it gets to M, people are no longer, usually with rare exceptions, doing surgical resections because we hurt people more than we help them. So the T stage depends on how far through the stomach, in this case, the cancer has progressed. T1, means it's confined. As you get through further and further layers and then eventually out and into adjacent tissues, you go from T2 to T3 to T4. The worse the number, the worse. N being if there are nodes positive where there is tumor detected in a lymph node, and then M being metastasis at a foreign spot. And it matters. So in stomach cancer, only 28% of cancers are detected localized, meaning without nodes and without distant spread. Regional, meaning going to lymph nodes, is still another 26%. And then somewhere around half it's already too late by the time we find it. And you can see how dramatically different survival is. If you're found localized at 5 years, you have a 70% chance of making it. If it's distant metastasis, it's 5.5%. So what we need to do is get more people here or even before here. So how do we do that? Well, we'll get to that in a minute, but just to show you what actually a pathologist sees, this is an H&E stain. So what's done is that a piece of tissue is processed, it's dehydrated, it's embedded in paraffin wax, and thin sections are cut. They're 5 microns thin, they're a little thinner than a human hair. And then they are stained with 19th century German dyes. And we've been doing the same thing for about 150 or 200 years, and it ain't broke, don't fix it. Like, actually, I was shocked after a PhD in molecular biology how much more we can learn from that one picture than from thousands of dollars of molecular testing. And part of the reason is because it's unbiased and it just shows you what it is. And part of the reason is because we have hundreds of years of really smart, thoughtful people looking at these, telling us what they mean and what to do about it. So if you don't have an H&E stain off of a tissue, you don't have a piece of tissue from most pathologists' perspective. Or if you don't have an H&E off of another one that you took at the same time as a reference, because it tells you what's there. So this particular one is full of what look like little blue ants, and that's because it's really an inflamed stomach. This is the inside. This is the outside. These are glands. Each one of these has a stem cell that's sitting in the middle that's making new cells that go this way and make new cells that protect, and then all the little blue dots that are around are nuclei, and many of them here are from immune cells. This slide actually has a little bit of intestinal metaplasia on it, which is here. These little guys that have what look like, we call them goblets in them, these little halos. That's a precursor for gastric cancer. And right here, there's a little bit of cancer that is quite subtle if you don't look at these all the time, but it's pretty obvious if you stare at these all the time. And you might ask, it's like when you learn to look at these, it's like learning a foreign language, but at the end of the day, once you speak the language, what's there is a horse and a zebra and a duck, and you just know what it is. How do you know that it is what it is? Because you've seen it 1,000 times, you know what it looks like. So, but part of the trick is, can we make that better? Can we make that easier? So this is the transposon protein stain. It makes it a little easier because all the cancer is brown. You don't really need to be a pathologist for that. And in gastric cancer, it's almost 100% that's stained this way. The intestinal metaplasia actually here on this case doesn't stain and often doesn't stain. So I'll get to why that is and how that works in a minute. But it's true in both the signet cell types, the diffuse types, and the intestinal types. And we're hoping that it can help us identify cancer early in different ways. So this is an immunostain of T1 gastric cancers with Jeremy Davis, a close collaborator who spoke here last year. And so backing up a minute, and I'll come back to the transposon in a minute, what is it anyway? Why does it kill people? Why is it hard to get rid of? So all cancers are made of billions of cells. They're old and complicated. They're heterogeneous and they're unique. And people say that everybody is unique, and most of the time they say that and don't actually mean it. Right? Most of the time, most of us are more similar than we are different if we cannot fight over politics. But we usually, there's so many of the cells, and so over time, what happens is cells that are normal get altered bit by bit by bit. And there's a bunch of safeguards and guardrails in place that are supposed to make it stop and to have the body kill those cells as they get altered. And over time, what happens is those processes break down, and eventually a clone grows out, a cell grows out with altered DNA that becomes cancer. And here it says cancer cell division is unchecked. I actually don't think that's a great way to explain it, and I'll come back to that in a minute. But the point is that the numbers are absolutely enormous. And the classical teaching is this, that cancer cell division is unchecked and it's uncontrolled growth. But actually, the cells in your stomach divide almost every day. The normal cells do. And in your colon, it is every day. And so if you think about it as uncontrolled growth, you're actually missing the point. The point is that the thing just won't die, right? It's not that the growth rate is too high. It's that it doesn't die when it's supposed to die. So how do we deal with this? And so the numbers, just to talk about the numbers for a second. So this is the number of cells in a cancer relative to the rate of cure. So a cancer that is, let's see if I can say this. So if you start at a roughly 1 centimeter cancer here, right? So this is 1 centimeter and then 2 centimeters. You have in the millions of cells. When you get up to 5 centimeters, you're at the billions of cells. By the time you get to 5 millimeters, 10 millimeters is 1 centimeter. At 1 centimeter, you're in the range anyway of a billion cells. And when a cancer is presenting at 5 centimeters, you have something like 10 billion to 1 trillion cells. So that's a big, big number. It's such a big number that our brains can't really think about it. But the bigger this number is, the chance of cure is less and less. So down is bad and up is good. So the bigger the cancer is when it's presented, the less of it lives up here in the we have a good shot of getting rid of it. And the reason for that is probably mostly due to heterogeneity in the tumor. So at baseline, about half of GE cancers are intrinsically resistant to the therapy that we're going to use first, as measured by CT scan. And unfortunately, the mutation status of the tumor, as read out on a sequencing report, as was asked earlier today, doesn't really correlate that well with how patients respond to our frontline chemotherapy. We're not really good at predicting, based on that, who's going to respond or who doesn't, which is kind of why everybody gets upfront chemotherapy. The new kid on the block is, of course, immunotherapy. But in all cases, what basically happens is you have cancer that has, at baseline, some heterogeneity, and then you kill almost all of it. And we're very good at killing almost all of it. We're just not good at killing all of it. And when we kill almost all of it, one of two things can happen. Either there was some resistant clones at baseline, which are here as the dark color, they don't die, and then they grow out. Alternatively, there really aren't resistant clones at baseline, but you add some pressure with the killing, and all of a sudden now one appears, and then that one grows out. And so when we do targeted therapies or chemotherapy at some rate, that's going to happen, and then the resistance are going to grow out, and then you hit them with the same thing, and now they don't die, or they don't die enough to make the therapy worth it. So, and here's a slide just showing PD-L1. So all of this big blob is a tumor, and only the brown part is PD-L1, mostly on the tumor, but not entirely. And we'll look at something that, if this is the sort of a postage stamp, we'll look at something that is roughly the size of that entire wall and try to count those, and then count how good they are. And actually, this is a place where AI is really useful, because when you have an entire wall full of things that look like this, and you want to quantify over the whole thing, AI is much better at it than I am. Much better. I can tell you if it's there or not, and I can tell you if it's a lot or a little, but making up an actual number out of this, at the end of the day, no matter how hard I work, I'm sort of just making up the number. So why do we do this at all? Why do we hit people with systemic therapy if it turns out that somebody's going to get a clone most of the time? Well, most GE cancer patients die of recurrent disease, and most of the thing that we expect that the reason people recur is that you have micrometastasis at the time of presentation, meaning the cat is already out of the bag. It's just too small for us to find it. And so if we have better systemic therapy, then we expect that we are going to get rid of those micrometastases, because our surgeons are very good at cutting out the local tumor. They're very good at that. So we think if we can get rid of these micromets, these little red dots that are in different parts of the body better, that we might have a better chance of curing someone. And not only curing somebody, but improving disease-free and overall survival. Okay, so that's the task. And so how can we do better? And the answers are actually really not really new ideas. Earlier diagnosis, better biomarkers and treatment paradigms. Prevention, that's one that doesn't get talked about a lot. And then new therapies and vaccines. And we're working a little bit down on all of these. And then I'll tell you why we think these transposons can be helpful. So our current surveillance has limited sensitivity. So a chest X-ray, about 1 billion cancer cells. A CT scan, about 10 million. ctDNA is great. Maybe 10,000 cancer cells could get detected. And then John Mullen on an endoscope, my friend at Mass General, can probably see about 1,000 cancer cells.
Wow.
On an endoscope. So if you're really good with an endoscope and you've done it a lot and you spend your time, you can see 1,000 or 10,000 cancer cells. They can find early lesions. He sits there, like many of these endoscopists who are very, very talented. You can find in an endoscopy about 10,000 to 1,000 cancer cells. But you have to be sedated and have an endoscopy, which has risks, which is also, it's also very expensive. And anybody who's ever had an endoscopy knows it's also very unpleasant. Right? So you don't want to be doing those. And actually in the United States, we don't do screening endoscopies for upper cancers because the prevalence is too low. In Korea, they do, where the prevalence is much higher and they save lives. But here, it doesn't reach cost benefit. So if we can find it earlier, it would be better. Sorry, I forgot to say. And so early detection improves survival. It's flat true. If we can find it earlier, survival is better. This has been shown over and over again across tumor types. And can detection of minimal residual disease or early recurrence improve outcomes? We're all hoping it does, and there's increasing data that it does in different contexts. Some of that is from things like the tests that Exact is running, where we can actually try to follow something live. So just to go over MRD again, it's already been talked about, but MRD, or minimal residual or molecular residual disease is sometimes said, is the presence of cancer after curative intent therapy while you cannot see it radiographically, right? So your scans are negative, your fancy PET scan is still negative, but we can use a molecular test to find the cancer. And that can come in the form of a DNA test or another test, being CA19-9, CEA, which are not that effective always in gastric cancer. It's a small number, or circulating tumor DNA. So what do I think the future is? Well, right now, what we kind of do is everybody shows up. If you show up with stage 4 gastroesophageal cancer, we're going to run up front HER2, MSI panel, PD-L1, and if those are all negative, then you're going to get chemo. And then at some point, the chemo's either going to stop working. How do we know? How do you decide? Then we're going to switch over and we're going to try a second-line chemo. And then if that stops working, then how do we decide? The idea, of course, of precision medicine is that we would find the right time, the right patient, and the right treatment, and we would put them together, and that would be a customized platform. So what would that look like? Well, you come in, and biologically informed, we have a targeted therapy, a vaccine, or a chemo or immunotherapy that we know will have a higher chance of working in you. And then we start there, and we're informed there by upfront molecular testing of the kinds we've been talking about. Then we don't wait until you have a PET scan show up positive later. We actually follow you and figure out over time, are you responding? And if not, then we think about what are our options. And then again, we have second line, again, biologically informed, and so on. And the hope is that this moves the needle in survival, right? Is that it doesn't just do a whole bunch of expensive things for no reason, and we do those because people actually do better. So that's the goal. So how do we get there? This is a trial that my colleague at Mass General and collaborator Sam Klempner and Matt Strickland have just finished accruing. The NALIRIFOX trial, this is essentially a modified FOLFIRINOX with a liposomal formula called NALIRIFOX. But the point of this trial is that we were going to do the best therapy we can, but we're going to take like 10 samples per patient longitudinally, so we can get blood at multiple time points, so that we can get tissue at multiple time points, and we can try to molecularly understand this. So we are actually starting to analyze these for our favorite markers, including the line 1 transposon, and trying to hope that we can start to learn molecularly what's going on so we can start to work our way there. A lot of work like this is going on at other major centers as well. So how do we do better in prevention therapies, vaccines, and transposons? Well, transposons, I've just showed you that they just light up cancers. The stain lights up cancers. So we've known since about 1993 that transposons could be involved in cancer biology. Actually, Bert Vogelstein was the first one to show this. They showed at Hopkins that a transposon had landed in a gene called an APC gene, which is a tumor suppressor gene. It had broken that gene, and that started a colon cancer by starting an adenoma. But it wasn't until we made antibodies to the transposon protein in around 2014 and stained about 1,000 cancers at Hopkins that we saw that this was actually really pervasive. This wasn't a one-off thing that was just that one patient, but actually across cancer types, these tumors were staining essentially more than 90% positive across major cancer types for the transposon. And then in the intervening 10 years, we and others have actually gone back and gotten better at the stains and made better reagents and better techniques. And we realized actually that our initial studies were underestimates. And what we have now found is that depending on the cancer type, these pie charts show that somewhere between 80 and 99% of different cancers are positive for this transposon protein. And what you can see here in this colon cancer is that the adjacent normal is just not. And this is we just published this at the end of 2023. This is 200 cases of colon cancer at Mass General. 91% of them are positive for overexpression of the transposon protein. What's really interesting, we didn't publish it in the study because it wasn't really what the paper was about, but so far, as of right now, the 9% who are negative, no one has died yet. So we're trying to do larger studies to see whether, with 211 patients, that sounds like a lot, but when you're only talking about 9% that haven't died, actually, it's not a big number. So we need larger numbers to make sure that this isn't because of some bias in our cohort and do multivariate analysis, but it's encouraging. And then here in stomach cancers, again, you just don't need to be the pathologist to find the tumor. They're brown. So here's this nasty diffuse type that's trickling through everything. Here's a more solid intestinal type. The normal stomach does not stain, and the tumor does. So this is, we thought that this might be kind of interesting because if it's in the tumor and it's not in the normal, you could use it as a biomarker. So you could see, is it present? And if it's present, that would be bad. And we tried to do this for a really long time, and it didn't work for technical reasons. And now we have these running. We just published our first study at the end of 2023. And showed that we can use it for early detection and risk stratification, as well as for monitoring patients. So this is a cohort of 19 gastroesophageal cancer patients from Sam Klempner. They were coming in at stage 4 for a mix of cross or immunotherapy. It was whatever they had taken. It's a retrospective cohort. And we had blood at the time of diagnosis, and we measured the transposon protein. And then we had a second blood sample taken between 30 and 120 days onto therapy. I think anybody in here knows who's been involved that at that time in gastric cancer, we have no idea what's going on. Right? We just don't know. The stomach's inflamed. The food is in the same place as the stomach if you're even eating. And it's very challenging on PET scans when there's inflammation to know what's going on. So absent an endoscopy, and even with an endoscopy, sometimes it's hard to know what's going on. And what we found was that for all the patients who responded, all 13 of them, the transposon protein felt undetectable in the blood. All 6 of them who responded, we could either still detect it or it went up. So here's one non-responder. You can see the liver mets got bigger. For this responder, here's the cancer. This is an axial PET CT. Sorry, this is the flat on, and here's the axial. You can see here, this black, that's the tumor. It's almost gone. Here's the stomach full of the dye, so that's confusing to people, but that's not the tumor. Actually, you can see it much better here. Here's a big light up tumor, and it's almost gone in this person. So this is the response we want. So here's one of our responders, one of our non-responders. And the p-value for being able to monitor this like this was 0. I had to go back and check with Matt Strickland, who had scored these, that we hadn't corrupted the data. Turned out it was true, it was correct, and actually the patients who actually didn't respond also, we noticed, had a higher baseline level of ORF1. So we were wondering if more line 1 protein in the blood could actually be a bad prognostic factor. And we did it out over the cohort that we had of about, I forgot now, was it about 100? It's about 100 gastroesophageal cancer patients. And what you can see here is if at the time of clinical presentation we either can't detect the protein in your blood or it's low, you do much better than if it's high. So this is just split up the middle. And this looks a lot like the circulating tumor DNA plot that you just saw. So what we don't know is actually what we're measuring here. Of course, we know we're actually measuring the protein level, but we don't know why that correlates with a worse prognosis if it's higher. We think it has something to do with tumor burden. But remember, I also just told you that the patients who are negative on the tissue and the colon cancers, none of them have died. So we think it might be some combination of the biology and the tumor burden, how much tumor there is. We're still trying to figure that out. So what are these things anyway? Well, human transposons, when the genome was first sequenced in humans, what was seen was quite surprising to people, which was that protein-coding exons are this little gray sliver of the genome there. And out of 3 billion bases, they make up less than 1%. Those are genes. And about half of the genome is hundreds of thousands of copies of the same few sequences called transposons. And a very famous biologist called them junk DNA, and nobody wanted to work on them because who wants to work on junk? And unfortunately, that set our field back for a while because it was hard to get funding to work on junk. But when I started working on this, I said, wait a minute, like half or more of the genome was written by these things in some way. How could this not be important? And what they are virus-like genomic parasites. So they're very similar to HIV. Actually, HIV and the transposon share a common ancestor. And what they want to do is copy and paste themselves to a new place in the genome. It's really simple. It's just a copy and paste virus that has a way to write itself into the genome. And it wants to hop, and about 1 out of every 20 babies has a new copy of this in their genome that wasn't in either parent. So we think it's just a parasite that's moving around a little faster than we can get rid of it. Weirdly, like megabats and some kinds of rats don't have it anymore, but it's conserved to plants. And if this sounds weird, it's because it's weird. We've been evolving with this for the better part of 4 billion years. Actually, as we've learned things about it, some of the things that we have found are conserved to rice. So this is a thing that all or almost all eukaryotes are dealing with. So here's how it works. We've animated it. The human genome contains approximately 500,000 copies of this virus-like element called line 1. In certain disease states, line 1 escapes repression and makes RNA molecules that go out into the cytosol, where they make 2 proteins that, like a virus, bind back to the RNA that encodes them, making a virus-like particle that tries to go into the nucleus, where through the action of a protein called reverse transcriptase, line 1 makes a new copy in a new place in the genome, causing a mutation and DNA damage. We've also learned that reverse transcription can happen in the cytosol, where it makes a thing called an RNA-DNA hybrid, an aberrant product that activates innate immune signaling, essentially inflammation in the cell. And now that we have developed a high-resolution understanding of the protein, we may be able to make small molecule inhibitors that might become effective therapies for prevention or treatment of cancer and other diseases where line 1 is implicated. So, sorry, that's a lot of biology really fast coming at you, but we made this video with a really talented group called Visual Sciences, and I hope the point that I'm trying to convey is that now that we can start to have a molecular understanding of how this thing works, we might be able to make a very specific monkey wrench to cog up the machines to prevent it from doing bad things to the cells. So the biggest thing is that some safe drugs, including what are called nucleoside reverse transcriptase inhibitors made for HIV, also happen to inhibit line 1 because HIV and line 1 have a common ancestor. So why am I telling you that? Well, if you have HIV and you take those drugs chronically and you can suppress your HIV, over large population studies, you have about half the risk of everybody else of developing cancer. Now, why is that? So if you lose control of your immune system and the HIV is winning, you have higher rates of cancer. And that makes sense because the immune system surveils and helps kill early cancers. But this way, it's going the other way. So that makes the effect even stronger. So we don't know why that is, but we think it's because these drugs are targeting line 1. And just, although it's not about cancer, and I know that's what everybody here cares about, and that's mostly what I care about too, what's even more striking is actually autoimmune disease and neurodegenerative diseases. It looks like you have about 3 to 4-fold lower risk, in some cases 5-fold, of developing things like multiple sclerosis and Alzheimer's disease. And actually the numbers for Alzheimer's disease are kind of crazy. This paper has been on bioRxiv for about a year. They've looked at 11 or 160 million people, and if you've ever taken these HIV drugs, you have about half the risk of everybody else of developing Alzheimer's disease.
Wow.
So we think that's because the target is line 1. There are a couple of other ideas that I could talk about as to why this is working, but we think it's because line 1 is contributing to cancer development and into progression, and also into some phenotypes of aging. So if that's true, then we should be able to do something about it. So inhibiting line 1 could prevent cancer and slow aging down. So multiple clinical trials have been done. My colleague David Ting did one in advanced colon cancer patients who had no other option, and in which 9 out of 30 had a biomarker response, and 3 out of 30 actually had a response on RECIST to a single agent. The trial did not meet its primary endpoint, but it was interesting enough to get a lot of us really thinking that there was something here. So what we want to do is to take these drugs, such as Truvada, which is the HIV drug that costs about $4 a day, and we want to use it for prevention trials. And our initial target is actually FAP, which is a hereditary colon cancer syndrome, because the risk of cancer is very high. But we're also quite interested to do it in Barrett's. So that's one side. And then the other side is, okay, what if we could just figure out a way, doesn't matter if the transposon actually does anything, it's there, it's in the cancer, it's not in the normal. Can we just use that to kill the cancer? Not a very complicated idea. Just use the fact that the cancer has this thing in it to find a way to kill it. So, sorry. So the one way that would make the most sense of that is that it might be what's called a shared neoantigen, which means that the immune system could learn how to recognize this and kill the cancer. So we would use that by making line 1 as a vaccine. Could we find a way to use a vaccine with this to treat patients who have cancer and have their immune system get reprogrammed and go kill the cancer? Or can we use that to make a therapy to prevent cancer in the first place? So we're working on this with a couple of groups at the Brigham, at Sloan Kettering, Cornell, and Columbia. We're not the first people to have this idea, although we have some new ideas about how to do it. And then the other thing that my lab is trying to do is to make drugs that might bind to the transposon and then use that fact that you could target the drug to the transposon to kill the cancer. We don't necessarily think that by stopping the transposon once somebody presents with cancer, it's going to be the best thing, but we think we might be able to do some other things to the cancer by being able to basically concentrate this drug in it. That's the idea. And the chemoprevention trial, just to draw out, what we're thinking we're going to try to do and we're trying to get funding for now is that we would take patients who have these hereditary cancer syndromes, would go in for a routine colonoscopy and leave some polyps behind in a way that is safe, take some samples, and then put a patient on a drug or a placebo, and then follow up with our biomarkers over time and then repeat the colonoscopy and hope that we can slow down the rate of new cancer development. And if that's true, then it would be generalizable to other cancers, including cancers of the stomach, where the same kind of mechanism is happening. So in summary, cancers are old, they're heterogeneous, they're complicated. Finding them early and preventing them from happening in the first place is the best cure, by far. Unfortunately, by the time that people actually present knowing they have a problem, that's often too late. And revolutions we are making are giving us new therapies that will let us hopefully improve care. I just want to highlight that everything I just showed you about the transposon is still too early. I would love to run your blood in my lab. I can't do it. But we are trying to get trials where we can do that, and we're doing these with MSK and with MGH and other centers. I just want to thank everybody for the stories and participating in trials. It's really inspiring and humbling to hear them all. It's an awful disease. And the courage that everybody has may not only help you, but help us do a better job for future patients. So that's a really big deal. Here are people in our team who you can contact if you need another opinion, as well as the great people who are here today. So we are hoping that the transposons, the dark genome, will provide hope for the future for stomach cancer. The transposon itself is an understudied hallmark of cancer that we think contributes to pathology by multiple mechanisms. We think it's going to be useful as a biomarker and in clinical trials for early detection, minimal residual disease, and risk stratification. We're working with companies like Exact and talking with Exact to see if we could add this into Cologuard version 17 or whatever the next one is called. And we could also think about using this in different paradigms, like for early detection, again, for risk stratifying patients. And then ultimately, we're hoping that we can make new therapies. So the biggest question for line 1 is not does it do something bad, but how much does it matter? We know it's contributing, but it could be a small contributor or a big contributor, and until we do the trials, we won't know. And then, of course, we want to kill cancer using line 1. And then I'll just say again one last time that preventing is curing. So there's not funding for prevention. It's really hard to prevent at the population level, but we're trying. So I just want to thank a lot of people, especially Aki and the Hope Foundation, for all the amazing work and all the patients today again. I have a lab. I've just moved to Brown in the last couple months. This is my lab, and a huge number of collaborators and team. Here's Sam and Andy Chan, who've been really leading a lot of the clinical work that we've done, and David Ting, who did the trial at Mass General that I mentioned. So thanks, everyone. And sorry, I hope that wasn't too much molecular biology in one place.
No. Thank you so much. This was amazing, amazing. So we will take questions now. Yes? No? Yeah, 15 minutes. 15 minutes of questions? Yes.
Oh, great.
15 minutes of questions.
Okay. Ready?
Please.
All right.
I was with Dr. Wu. I kept a question. You showed us a slide that showed HER2 negative, and then there was a HER2 positive over here. Can it possibly be missed because they saw the wrong one or saw the wrong? I mean, that would be very disturbing to me if somebody told me, "Oh, you're HER2 negative," but yet it was positive in another slide. Does that make sense to you?
Yes, so in fact, I'm so grateful to have a bona fide pathologist instead of a highly amateur pathologist here to address that phenomenon of heterogeneity, where you may have some cells within a cancer that are HER2 positive, negative. But Dr. Taylor, would you like to?
Yeah, I think this was a question that was asked also. We were just talking about this on the last panel, which is there is some heterogeneity. So if you're in the case where you're like Dr. Wook's tumor, where it was just screamingly HER2 positive, it's almost never going to get missed. But the ones that are more heterogeneous, that are sort of on the borderline of do we treat them or not, can easily be missed. And so, as was mentioned before, we would recommend that when people are going on to therapy, if there's a new biopsy, we want to test it, right? And that if there is both a biopsy and a resection and there's still tumor on the resection, that we repeat those critical biomarkers, because if there is positivity that was missed, you might see it there. Does that make sense?
Yeah, it does. I was just wondering, had it ever been missed before, or is it that's why the doctors now, when they do a biopsy, they do it in different areas and they have different slides, so it's possible that this is a negative and this one's a positive. So once it's a positive, it's a positive. But if it's a negative, it's not necessarily a negative. You keep looking. Yes, you keep looking? Okay.
And depending on how positive it is as well.
Anybody else have any questions?
So with the transposons, you were saying that, when you say line 1, that refers to the transposons?
Yes.
And when you say ORF, that also is referring to
Sorry,
the
it is confusing. I tried to be brief, but maybe I was too
okay.
brief. So so the only remaining active human transposon is called line 1. Okay. And then line 1 makes 2 proteins, which are creatively named ORF1 and ORF2, where ORF is a geneticist's term for open reading frame, which just means it probably makes a protein. So it's been an ongoing debate in the people who work on this as to whether we could rename them into something that isn't so inane. And then people have accused me of barking like a seal because I just say ORF over and over and over again. And actually, when we solved the structure of the ORF2 protein, that right-handed kind of multicolored thing that was up on the corner, one of my mentors said we should rename it and give it a new name. And I wanted to do that because it's a terrible name. But who am I, right? People have been working on this for 20-something years. Who am I to rename it? And actually, afterwards, one of the reviewers of my paper told me that if I had tried to do that, he would have rejected the paper regardless of how good the science was. Unfortunately, we're just stuck with these names, ORF1 and ORF2, for the 2 proteins. And you can imagine how many times in our conversations in the lab, so one of the people in the field, Kathy Burns, who's my mentor, who was on the acknowledgement slide, she actually has called them the marker and the mutator, which is a little bit more convenient. So we're calling ORF1 the marker because it's present at very high levels. The transposon uses it as a chaperone. It basically gets the thing into the where it needs to go. And then the ORF2 protein is the business end. It's the mutator. It's what mutates the genome. So does that make sense?
Yeah. So when you're doing that staining and it's all turning up brown,
that's ORF1.
It's the proteins that
it's
are
the ORF1 protein.
Okay.
So what we're looking for in those tests is the protein itself. So what EXACT is looking like is almost entirely the promoter. So in order to make the protein, it has to make the RNA, which is that thing that was coming out of the nucleus that looked like a pink spaghetti. So in order for that thing to get made and the transposon to be on, the DNA has to get turned on. And the way the DNA is controlled is with what's called methylation. So it's been known for 20 years that in cancer, line 1 promoters, which is the part that tells the cell to make it, are hypomethylated. And what that means is the way the body keeps those virus-like things off is by shutting down their promoter by methylating them. And in cancer, that breaks down across the board, which is why the EXACT MSED tests work. Because they show, among other things, they have, you can look at methylation of those sequences and then also other sequences, but mostly it's most of the weight in all these tests is that methylation. It's also how Grail's tests work. So they find that methylation is gone, and then you can make the RNA. And then what we're finding is that not only can that methylation go away, but then you can make the protein. And what's interesting is that they don't always tell you exactly the same thing, because it's more complicated than that. And I don't want to bore you with why it's more complicated than that, but the two appear to be synergistic. So we are showing in multiple contexts that finding that protein is a marker of either malignancy or a pre-malignant state that is bad. And so if we can find that, we know it's bad. So over about 400 people whose blood we've tested, only 4 of them who were healthy had it in the blood. And one of them 6 months later is found to have an advanced prostate cancer. We've done this in other cohorts as well, like 30 chronic liver disease patients. The one who's positive ends up with an HCC. So these are the kinds of conditions where, you know, we would like to start running more tests, and where the tests that, like the one Michelle was showing, would be super useful, right? Because you can hopefully risk stratify those people, or maybe find something that's a problem before it's too late.
I'd also like to add, is my microphone on, or do I have to turn it on?
I don't know.
I don't know if it's on. I'll just say it out loud.
Maybe push that button. Oh, you got no dice.
No dice. It's okay. You can hear me, right? I have kids, so I can hear.
The live stream, you can talk to
Try
the
now?
live.
All right, perfect. Oh, thank you. Thank you. Now I almost forget what I was going to say. I would also add to the idea when you talk about the methylation that it does change, right, in your body as you age. So there's a number of different factors. Thank you. Sorry. There's a number of different factors. No, I can't hear it. Killing me.
Here, try this one. This one's on.
No, it's fine. There's a number of, there we go, perfect. There's a number of different factors that contribute to methylation in the body. So as you age, your methylation levels go up, right? So you need to be aware of that as well. So methylation is fantastic, but you have to take it into context, number one. Number two, there's also cancers. They have different dwell times, and we're trying to monitor those as well. What you mentioned signaled something to me. That's a big concern about the technology, which is you measured a molecular signal in the blood. I went to look for that signal via an imaging test, but I didn't see anything, right?
Then what?
Then what? But later on, that person was shown to have, pancreatic cancer, right, which is very aggressive. So did your test actually identify a molecular signal that exists that you otherwise wouldn't have seen with imaging? So we have to take all these things into consideration with these new technologies. But you're leveraging the body's information to identify something that's, awry, that's wrong. But there's concerns that people have about it.
Yeah, and on that point about how new it is and how we have to think about it. So major cancer centers around the country are actually full of what are called MCED clinics now, where people are running these tests either on their own or they have been run, and then they come back positive. And here you have an average risk, otherwise 50-year-old or 40-year-old or 60-year-old who has a positive molecular test, and then you run a CT scan or a PET CT scan and you cannot find anything. So what does that mean? And we don't yet know, and we have to figure out what are the right algorithms, how do we sort that, how do we figure out what to tell that person, and how do we not cause people more harm by doing things to them that they don't need. And we're just very early in doing this, and so there are going to be some growing pains. But that doesn't mean that it's not worth doing it. It's very important that we learn these things and we figure out how to actually use these technologies to catch cancer earlier and then be able to intervene.
It's to piggyback on that question to identify the cancer and find it. You had mentioned just now that it's hard to see in PET scans, CAT scans, but you also said it was not cost benefit to have an endoscopy, which most of us, that's the only way it was found. So can you elaborate on that a little bit?
Yeah.
Like, what should we go and ask for?
Well, so at the population level in the United States, screening upper endoscopy for gastroesophageal cancer is not recommended by the preventative task force right now. And the reason for that, it's a low-grade recommendation, and it's not always something that's pushed forward. And the reason for that is just the curve that we just saw with the incidence versus the essentially the incidence. Yes, exactly. So how many screenings do you have to do to find a cancer? And so for an upper endoscopy for gastric and esophageal cancer in the United States, it's like 1,000 people, give or take, that have to get screened to find one positive. So where you have other factors like obesity, alcohol use, reflux, that we know contribute, H. pylori, now we start going in and we do endoscopies. But it's not recommended that when you turn 45, like for colon cancer, that everybody in the entire country gets an endoscopy. That's not true in East Asia, where the incidence is higher. So in Korea or in Japan, the incidence are higher. And in Korea, there's a nationwide screening program where everybody gets an endoscopy, and it saves lives. So it's not that endoscopies in the United States don't save lives too. It's just that the number of people who have to get one to catch a positive early is higher. Does that make sense? So it's just a matter of the government trying to figure out where do we spend money and what do we put our entire country through in order to find a small number of people. So the hope is that, for example, we get a blood test working with some combination of line proteins, methylation, other biomarkers, and everybody does that every year, for example, or every 3 years or something, right? And you have your baseline level maybe even, and then you change, or maybe your level is off. And now you go in and you get the tests that are more sensitive, where instead of needing to find 1 billion cells, you could detect 10,000 or 100,000, and you could find the different sites. And then depending, hopefully, as we get better at this, maybe the test says, you're probably a little bit more likely to have ovarian cancer or stomach cancer than you are, for example, pancreas. And then we might be able to target what we do next based on that. But we don't yet have that algorithm. But that's what we're going, I hope.
I mean, as you're talking, I'm just, here we go again. Can you hear me? That's perfect. As you're talking, I'm starting to think about, even looking at risk algorithms that are present in clinic, you pop some numbers in and determine your overall risk. Certainly, those are things that people are going through. I wanted to circle back on the cost, outside of the stomach cancer realm and related specifically to the MCED technology. There's 2 actual approaches that exist once you get a positive result as part of an MCED test. Okay, so there's an imaging-based an imaging-based diagnostic resolution pathway and a molecular diagnostic resolution pathway. I'll start with the molecular one. On the molecular side, what they do is they leverage all that methylation that we were talking about earlier in the sample, and they say, based on our algorithms that we have, that cancer is most likely present in this organ or this organ. And so the physician then says, okay, I'm going to go do an endoscopy to look for that, or I'm going to do a CT scan, or name your favorite imaging modality. We don't offer that as part of our technology. It's often called a tumor of origin approach. We offer the imaging-based diagnostic resolution pathway. So once you get a positive result with the CancerGuard test, the physician then is directed to order the patient a CT, IV contrast CT, to look for the cancer. If it's negative, then you proceed to a PET. But if it's positive, you stop there, and then you go through the potential need for the biopsy or TNM staging and all of that. So what we've demonstrated recently, it was initially published in bioRxiv, and then it was published in an academic journal recently, was that the imaging-based approach is in fact more efficient for patients. It's ultimately, we didn't look at cost, but you're getting less procedures and less exposure to radiation following that imaging approach. And that's mainly because the majority of the results that you get from an MCED test are in fact false positives. So let me put it a different way too, because you're probably thinking there's a lot there. But it's about 1% of the population that you test is going to have a positive result. Of those positive results, the majority of them are false positives. So it's still a very small number. But the reason that's important is because if I don't get a positive
on the first scan that I get, I'm going to go on this diagnostic odyssey to try to find it, and it's not there in the first place. So doing a simple imaging approach is actually more efficient for the patient, and ultimately long-term it's more cost-effective.
Yeah. So stated another way, when you run a blood test, you kind of have a choice to make up front, and as we get better and better, the trade-offs will hopefully improve, but there's a choice when most people who are getting the test, no matter what, don't have a problem, is how many do you call positive and what is the threshold? And you have, it's really there's a trade-off between how many people who don't have the disease get a positive result and get unnecessary testing versus how many people do you miss. And so hopefully we can continue to improve the algorithms and maybe, for example, behind the scenes, run one algorithm up front, and then only if that one's positive, run the next more expensive test, for example. And actually, before anybody gets anything back as a patient, multiple things have actually been done. Multiple tests have been run, and that together helps provide a cleaner experience and a better performance characteristic for the test. But we're not there yet. Right, so we're still at the point where you're getting not quite raw data back from these companies, depending on the company and how polished it is and what you're getting and how clean the result is and how much evidence supports it. And patients and oncologists and pathologists are sort of having to figure it out together. And hopefully the goal is to go from that to having a much more structured, guided approach where we know the answer to all of these questions that we still don't know.
Thank you so much. I thought this was an amazing session. I've learned so much. I could sit here and listen more so I can explain to my patients a little more about these tests. This was amazing. Way to make pathology exciting. I think it's a skill. Well, this is awesome. Thank you. Thank you again, Dr. Wook, Dr. Beidel, and Dr. Taylor, really. Our final speaker of the day is Shannon Rondier. Shannon Rondier is a director based in Levitt's Partners, Washington, D.C. office. She provides federal policy counsel and analysis to clients and manages multi-sector alliances, bringing expertise in coverage and payment, focused primarily on Medicare, Medicaid, the dual eligible population, and drug pricing issues. Prior to joining Levitt Partners, Shannon worked as a senior healthcare analyst at Ripple Effect Communications, where she reviewed public comments from various physician associations and individual physicians on CMS proposed Medicare regulations. She also served as a researcher for Professor Sarah Rosenbaum at the George Washington University Law School, where she analyzed the Trump administration's Medicaid demonstration waivers related to work requirements and eligibility, the administration's managed care regulations, and pending legislative reforms pertaining to Medicaid and public charge. Prior to these roles, she represented hospital systems in Medicare and Medicaid reimbursement matters in private law practice. Please welcome Shannon.
Hey, good afternoon, everyone. It's great to be with you. I am getting over a cold, so if my voice sounds a little raspy, that is why. It's such a pleasure to be talking with you all today about an issue that I think is very close to my heart and very close to this organization's heart. Thinking about the impact of federal policy on access to treatments for rare diseases, including rare cancers. And just to give you a little bit more background, I serve as an advisor to the Save Rare Treatments Task Force, which Hope for Stomach Cancer is a member, and we are really dedicated to making sure that there are protections in place for innovation into new treatments for rare diseases and rare cancers. As many of you know, rare diseases, there is a significant number of people with rare diseases, but less than 10% of those diseases have an FDA-approved treatment. When you think about access, there's a kind of a couple of different paradigms that I put them in. When you think about diagnosis, the panel that preceded me talked a lot about access to a diagnosis. What are the diagnostic tools that are being developed for cancer? What role do federal bodies like the FDA and the U.S. Preventative Services Task Force play in access to those types of diagnostic tools? what roles do the federal government play in coverage for those tools? So that's kind of one aspect of access. Another aspect, which the task force is mainly focused on, is how access to innovation and research for new treatments for rare diseases and rare cancers plays out. How does the federal government make sure that there are incentives for private actors to invest in research for rare diseases and rare cancers? How does the federal government directly fund research for rare diseases and rare cancers? Those are important questions to ask, Congress and any administration. And then there's a third aspect as well, right? How do patients who have that diagnosis, who have, a potential FDA-approved treatment on the market, get access to the right provider and the right treatment, right coverage for that treatment to make sure that they can receive the help that they need for their disease or condition. So, as we think about access, it's a really broad term, and I think about it in those three buckets. And today I want to tell you a little bit more about some of the work that the task force is doing around that second bucket to make sure that there are those incentives in place around research and development for treatments for rare diseases and rare cancers. So the issue that our task force is working on is around Medicare's new drug price negotiation program. Medicare's drug price negotiation program sets up a new system within the Centers for Medicare and Medicaid Services to negotiate the price that Medicare pays for certain high-cost drugs. The design of the negotiation program has an impact on the research and innovation landscape for rare disease innovation. And one particular aspect of the program that the task force has concerns with is how the program treats orphan drugs. Orphan drugs are drugs designated by FDA that treat less than 200,000 people in the U.S., and there are certain incentives that the government provides to manufacturers who are developing treatments for those types of drugs. I think in recognizing the importance of orphan drugs for treating people with rare diseases and rare cancers, the Medicare drug price negotiation program excludes orphan drugs, but it's a really narrow exception, and it only applies to drugs that treat one rare disease or one rare indication. So I want to talk a little bit more about the importance of orphan drug incentives. So for a number of reasons, there are difficulties in incentivizing private investment into rare disease treatments. Understanding a lot of those difficulties, Congress in 1983 passed a bill called the Orphan Drug Act, which creates some incentives to spur innovation into rare disease and rare cancer treatments. Some of the benefits of that law are a tax credit, an application user fee waiver, orphan drug exclusivity after approval, as well as research grants. You can see some of the impacts of that law, right? There was a 1,500% increase in the number of FDA-approved drugs after that law passed, from 38 to over 600 therapies. This was a really significant piece of legislation. It continues to be really important in the rare disease and rare cancer landscape, but we still know that less than 10% of individuals with rare diseases and rare cancers have access to an FDA-approved treatment, so there's still significantly more work to be done. A quick, just kind of definitional piece here that's important for understanding the impact of the Medicare drug price negotiation program and its interaction with the Orphan Drug Act. So, FDA, in granting some of these incentives to manufacturers who go to study treatments for rare diseases and rare cancers, an orphan drug designation is granted to a company pretty early on in the research process, so that they can research a drug with those incentives under the Orphan Drug Act. That can sometimes occur years before that drug is approved by the FDA. And then in orphan drug approval, FDA approves that particular drug under that designation for use to treat a certain type of disease. So I looked at the database today. There were over 90 orphan drug designations for gastric cancer. A number of those have resulted in approvals. Some were withdrawn and were not eventually FDA approved, but there's a lot of research into rare types of cancers that manufacturers are using and getting some of these incentives to do so. So the orphan drug exclusion. So within the Medicare drug price negotiation program, there's a narrow protection for orphan drugs, but it only counts for one rare disease approval. So, once a company goes to get another designation for another rare disease, that company loses the protection of the orphan drug exclusion. There is also an issue with how it counts the clock start for when the drug becomes eligible for negotiation, kind of going backwards to its initial approval rather than looking prospectively after it loses it. This is important because, a lot of rare diseases and rare cancers are not studied in a vacuum for one disease or one indication. There are a number of drugs that have been repurposed to look at other types of cancers, other subsets of cancers, and under this law, those particular drugs would not have protection from negotiation. And while this doesn't undo the bipartisan incentives from the Orphan Drug Act, it heavily impacts those incentives. And our task force has some concerns about the impact on the future of rare disease and rare cancer research in an environment where some of those incentives are impacted by this law. So there's been some research to date, right? The negotiation program is fairly new, and this evidence is still being gathered. There's been several public examples of manufacturers who have pulled back on studying a second rare disease or going after another designation because of the Medicare drug price negotiation program and the orphan drug exclusion. And there have been some academic studies of what this impact may mean over time for rare disease and rare cancer patients. You can see some of the stats there around reduced medical research, the loss of collective years of life, and the loss of investment in rare disease research and development. And this is obviously a concern for the task force given the number of folks that are still waiting on any FDA-approved treatment for their rare disease or their rare cancer. So the task force is working with members of Congress to pass a piece of legislation that was recently reintroduced in Congress that would address both of the key issues in the orphan drug exclusion. It would make sure that as long as a drug is only approved or designated for rare diseases, it remains exempt from those drug price negotiations. It also clarifies the time when the government would start counting a drug towards negotiation. This is particularly important for rare cancers and ultra-rare diseases because this ensures that there remain incentives to start with an ultra-rare disease or a rare cancer, and there isn't a concern about CMS going back with their clock to that first approval when it does lose that exclusion. So you can see a little bit more detail here on the Orphan Cures Act. It was bipartisan reintroduction last week by Congressman Joyce and Davis. There's a number of folks that have signed on to the bill. Last Congress, it was bicameral, also a Senate introduction, and we expect that introduction again this year. But this is a high priority for the task force because we see the importance of protecting innovation into rare diseases and rare cancers and ensuring that folks with those diseases, have access to that diagnosis, have access to those treatments, and ultimately have access to some kind of approved treatment. We have, some folks in our task force who talk about the idea of, there's a lot of concern around affordability and drug pricing, and just really wanting to be in a place where they can have that discussion because right now there's just nothing on the market that treats their disease effectively. So, that's a little bit about what we're working on, and I'm happy to take some questions from folks, whether we have time now or during the dinner section, but I'm happy to talk with you all a little bit more about this issue and about, other federal policy developments that are impacting access. And just a last slide there, I think I've said this stat several times, but really important to remember when we think about these incentives that there are really such a low number of people that have access to an FDA-approved treatment specifically for their rare disease or their rare cancer, and we'd like to see an increase in that. I know the panel before me talked about some really exciting developments in developing those diagnostics and those treatments, and my role in the task force's role is making sure there's bipartisan incentives to make sure that manufacturers and other researchers are looking into those treatments into the future. that's all I've got.
Thank you so much for
Yeah,
speaking.
thank you.
Thank you. I think we are going to save time for questions later in the evening. And I would like to thank all of you for being here and for letting me chair the session in the afternoon. It was, again, a pleasure to be here. Thank you for the invitation. And I would like now to call Mahathi Vujala to come up.
Thank you, Shannon, and thank you, Dr. Uboha, for leading our afternoon educational session. Is this on? Yeah. We appreciate everything you're all doing for us. I'm Mahathi Vajala. I am a stage 2B gastric cancer survivor. I was diagnosed in 2022 and completed treatment at the end in December 2023. I just wanted to briefly introduce myself and just kind of go over some housekeeping rules before we end this evening to get ready for our next portion for advocacy. And Shannon, I think you'll have more questions during that portion. We'd like to play a quick video on advocacy.
The journey from now to get it passed is going to be a lot of work for a lot of people, but I believe that it's going to be worth every ounce of energy and work that we can put into it.
I explained to him that we needed funds for early detection.
The fact that the level of care and the success rates are so much higher in Asian countries.
This is a deadly cancer and it can be prevented if doctors would just do simple tests.
Got all this great research going on that can't get off the ground because NIH doesn't have the funding.
Brought to his attention that breast cancer gets $500 million and we get 13 million, which is a drop in the bucket.
Because just saying chemotherapy is all we have for you is not enough.
All the cancers, it seems like if you have a little bit of money, you might survive it. If you don't have any money, you're not getting that surgery and you're not getting that treatment and you're going to die. And that's why we need to get this funding and get this ball rolling on this early detection for everybody.
Okay, before we go into tonight, I want to do a final thank you again to all of our sponsors. They're all listed here who sponsored this Empowerment Summit, which I think all the patients and caregivers would agree that has been very, very helpful and educational. This week would not have been possible without all of our sponsors, so thank you again. And to those who are joining us on live stream, we will now be ending our session. So we hope you've enjoyed yourselves and have learned a lot in these past few days. You can always find these videos and sessions available on the Hope for Stomach Cancer YouTube channel. So thank you so